with wonderful support, with wonderful support from the American Society of Hematology. We could not have done it without them, and they're much appreciated. Um, Looking forward to the day. I have prayed to the tech gods this morning, so hopefully everything will go well. And I'll be back a little bit to talk to folks a bit later, but for right now, I wanted to introduce the administrator of CMS, Chiquita Brooks-LaSure, and she will be joining us virtually. She is the administrator where she oversees CMS programs, including Medicare, Medicaid, the Children's Health Insurance Program, and the Affordable Care Act, health insurance marketplaces. She's going to start us off this morning, and hopefully a great day to come. We'll give her a minute. All right, well, she's what? Okay, well, I'll start saying a few things while you let me know when she's online. So my name is Ron Klein. I'm the Chief Medical Officer of the Quality Measurement and Value-Based Incentives Group in the Center for Clinical Standards and Quality. I'm a proud pediatric hematologist oncologist by training. So 20 years in full-time practice before I came to Washington, D.C. as a Robert Wood Johnson Foundation Health Policy Fellow. Like all of you in the room and joining us online, I'm passionate about sickle cell disease. I've taken care of lots of kids with sickle cell disease. I've gone to more than my share of funerals of kids with sickle cell disease, and we need to figure out a way to make sure that the care is as good as it can be. And so I think that's why we're all here today. There are opportunities for us to get better. We need to seize those opportunities. There are challenges in doing things in federal government programs, and we need to overcome those challenges. And we're here today basically to talk about how we do that. Those of us in the federal government want to hear from folks in the sickle cell community as to where the gaps are and how we can create measures that fill those gaps, if you will. The first half of the day will be folks from CMS, folks from HHS, all our federal partners talking a lot about what our programs are like, what we can do, what we can't do. And then the second half of the day, after we've prepared you with that baseline knowledge, will be to have a free-flowing discussion to talk about how we can overcome those challenges and improve quality for sickle cell disease, where there are enormous gaps. We know that doing in this crowd, we know that doing transcranial Dopplers prevents stroke, and yet I think half the kids who should get them have transcranial Dopplers. We know that being on antibiotic prophylaxis, getting the appropriate immunizations prevents death from sepsis, and not everybody who should have it gets it. So the question is, how do we make that happen better? And with that, Dora, I think if the administrator's not on, I'll introduce Dora Hughes, who is please come on. Who is the director of the Center for Clinical Standards and Quality, and also the Chief Medical Officer for CMS.
Good morning. I don't normally come up with my cell phone, but I did just get a text. The administrators, they're having computer issues on her side. So she is definitely joining. She said she might be a couple minutes behind. So I'll start, and then when she joins, I could, if you certainly just give me the signal, and then I'll stop and turn it over for her. I do want just to thank all of you for joining, those in person, the mighty, the proud, the few. I'm not sure what the right acronym, and all of us are joining online. We are so excited to be able to have this session today. And I'm grateful, as Ron mentioned, we are certainly grateful to our colleagues, the American Society of Hematology at ASH, for helping to support this event. We are really hoping to hear from you. We hear a lot about the challenges of why we can't do quality measurement, the difficulties, and we will certainly touch on these challenges today, but we especially want to focus on what we can do and what we will do together. As many of you know, there's about 100,000 individuals with sickle cell disease in this nation. On average, even today, with all the advances in medical science, they still live on average 2 decades. Their life expectancy is 2 decades shorter. And in addition, individuals with sickle cell disease are often challenged with debilitating pain, organ dysfunction, infertility, frequent visits to the emergency departments, and hospitalizations. And we here at CMS, as many of you, have a special accountability and responsibility for improving the care for these individuals and their families. We are excited about the new medications that have just been approved and other therapies. And at CMS, we are quite focused on how do we ensure access and coverage for these new therapies. But at the same time, and as Dr. Klein alluded to, we know that there's so much that can be done with basic medical care that will have significant impact on the quality of lives for individuals with sickle cell disease. I am going to, I believe the administrator is now able to join, so I may shorten my talking points, but I do just want to say that for us here at CCSQ, the Center for Clinical Standards and Quality, for those of you that are less familiar with CCSQ, we have the lead on quality of care for CMS, both through our quality improvement programs, through our quality improvement organization, QIO program, but also we're the lead on quality measure development, our quality reporting and payment programs. We operate these programs for nearly every healthcare facility in this nation, including hospitals, emergency departments, ambulatory surgical centers, critical access hospitals, rural emergency hospitals, over more than 20 different quality reporting programs. And so that gives us, we think, significant leverage and opportunities to incentivize higher quality of care for our beneficiaries. I think that, and if I could give me a thumbs up when the administrator is ready to start, and I could roll it right over to her. She's going to share more remarks on our model and program. So why don't we stop there? Again, Administrator, thank you so much for helping us to formally kick off the day. I'm going to turn the mic over to you, and then I will resume when you finish.
Well, thank you so much, and apologies for having computer issues. Are you all able to hear me okay?
Yes.
Great. Well, I'm glad I was able to hear a little bit from my colleague, Dr. Dora Hughes, who has been just such a leader across the agency in helping us to make sure that we are focusing on all people that are served by our programs. I like to say the 3 M's: Medicare, Medicaid, and CHIP, and marketplace coverage. And it's really been just a privilege for us to take a deeper dive in making sure that all of our programs, all of the work that we are doing is really looking at everyone, including people who have sickle cell disease. And it has been a priority of this administration, of the department, certainly of the secretary. And I want to start by saying just how much we want to thank you, all of you in the room, for your partnership with us in helping to raise awareness as we try to think about how to best implement programs across the board, and how much we are committed at CMS to making sure that we are looking at everyone who is served by our programs. And as you all know very well, people who suffer from sickle cell disease are often some of our most underserved, many of whom are Black and not getting the care that they need. We have heard in particular just about education that needs to occur on treatments, and just how the cost of treatments can sometimes be really prohibitive. And that is why one of the steps that we are taking as an agency is to really look at sickle cell disease. This is the focus of our model that we launched earlier this year, to really focus on how can we make sure and ensure that therapies coming to market are affordable for the people served by our programs, as well as for the programs that people are enrolled in. And we are excited about the cell and gene therapy model, which has its focus in sickle cell. As you probably know, that model launches at the beginning of next year when states will be able to start participating. That's just one of the areas and places of focus for us as an agency. And again, want to just say how much we appreciate all of the feedback we have gotten over the last couple of years and want to continue that dialogue, of which, of course, today is a part. I'm sorry I can't be with you in person. I need to be in Baltimore today for other meetings, but I am going to turn it back over to, again, my colleague, Dr. Dora Hughes, who is really focusing for our entire agency on sickle cell disease, as well as many other important roles in for our center. Thank you, and enjoy the rest of the discussion.
Thank you, and thank you so much. I generally try not to speak after the administrator. I know how that can go, but I would say, even as she has departed early, when the administrator came into this new role, she said that she wanted to host a series of listening sessions, that she wanted to hear directly from beneficiaries, provider groups, families, caregivers. And among the top of her list, the top priority were hearing from individuals with sickle cell disease and the groups that represent them. And I really think it's with her leadership that we've been able to, CMS has really taken a step forward in thinking about how can we better, again, address the access challenges that many individuals face, but also quality of care, which is why we're here today. As I was trying to filibuster a bit until she was able to join. And so I'm not going to go back and sort out where I was with my talking points and trying to figure out what can I say a little bit now, a little bit later. But here again, for CCSQ, for those that are less familiar with our center, the Center for Clinical Standards and Quality, part of our job is to ensure that nearly every healthcare facility in the nation is offering high quality, safe and equitable care for our beneficiaries. We do that across the range of settings, and we do it for individuals across their care journeys. And we do it not just, our scope is not just individuals with Medicare, Medicaid, and Marketplace coverage, but because of our regulatory scope, we touch facilities that only take commercial insurance as well. It goes beyond the 3 M's to really encompass all the different payers. And so that provides us special authority, special leverage, and we very much intend to set the bar high to really think about what are some of the ways that we can improve, whether it's offering more of the basic medical care services that Dr. Klein alluded to, or thinking about what are other special considerations for some of the newer therapies that are hitting the market. But for all of that, quality measures is especially key. I think we would all agree that there's a paucity of quality measures that address not just the clinical care, but also the experience with care. And this is why we're here today. This is what we're hoping to think about moving forward. What are all the quality measures that we have? What are those that are in the pipeline? What are some of the newer quality measures that should be developed? What are the new areas that we haven't even focused on adequately to date here at CMS through our programs that we might want to consider? So this is very much a listening session, but in my head, this is the first of many listening sessions to come. This is a working group session. We're hoping to hear your best ideas, your strongest recommendations, because again, with the leadership for our administrator and just the excitement and the involvement, the engagement of all of our federal partners, and particularly those that are sister agencies, we are excited about what's to come. And so with that, I'm going to turn the mic right over to our next speaker to just arrive, to come straight to the stage. Thank you so much.
So it's my pleasure to introduce Dr. Fasipe to you. She is representing the American Society of Hematology today, and they've been wonderful partners in putting this conference together. She serves in integral roles, including leadership on the ASH Technical Expert Panel, developing sickle cell disease quality measures. She's a member of the ASH Committee on Practice, and she is chair of the ASH Research Collaborative and the Sickle Cell Disease National Community Advisory Board. She is the co-director of Texas Children's Sickle Cell Disease and Thalassemia Program. She's an assistant professor of pediatrics and hematology oncology at the Baylor College of Medicine. Thank you. She just flew in, and boy, are her arms tired. No, just.
Thank you so much, Dr. Klein, and thank you I just have to say to Dr. Hughes and Dr. Klein, there is immense gratitude for how you have been championing sickle cell disease. I think Dr. Hughes may or may not remember, but a couple of years ago, I had asked on a panel where she was speaking at a sickle cell conference. And I said, what is CMS doing for sickle cell disease? I want to understand. And I didn't know that there were already some initial things going on, which we're going to discuss today. But then a few months after that question, I saw CMS Sickle Cell Action Plan. And then after that, I kept on seeing one after another new things brought out by CMS, thinking broadly about what it means to improve outcomes for sickle cell disease. So I just want to say thank you for doing the work to investigate what it means to prioritize sickle cell disease. And you'll hear later today how Dr. Klein also has championed a specific measure, which we'll discuss further. I am, as Dr. Klein said, I am representing American Society of Hematology. I'm a pediatric hematologist by training, but I'm also representing myself as an individual with lived experience with sickle cell disease. And part of that lived experience is not always getting my ducks in a row. So thank you for the graciousness of me being a few minutes late today. Thank you. And as I'm calming down and getting ready to dive deep into today's serious discussions, I want you to know that the work that you're going to hear about and the various federal agencies that you will also learn from, this has been a culmination of several years, blood, sweat, tears, and lots of behind the scenes entities. This has also been a labor of love and work from those in the sickle cell disease community, and we appreciate being included in these conversations. You'll hear from a representative today, but we want you to know that having a seat at the table and where these large national conversations are being led and run, it means the world to me and so many others. And so with that, I'm going to pass it back to Dr. Klein, but I hope to talk a little bit more later today. Thank you.
Thank you and welcome. So it's my pleasure to introduce Mariah Scott to you today virtually. And we are pleased to be joined by her. She's a sickle cell advocate, and I will let her share her story with you, but we are pleased that she joins us with her many perspectives today. And she is a sickle cell advocate, a researcher, and she just started pursuing her PhD in preventive science at Rutgers University. So, Ms. Scott.
Thank you so much, Dr. Klein. Can everyone hear me okay? All right, thank you. First, I want to thank the American Society of Hematology and CMS for inviting me today to not only give my lived experience, but the importance of quality measurement, especially during Sickle Cell Awareness Month. Also being a sickle cell advocate and living with sickle cell. It's so nice to see so many federal agencies coming together and working together to improve sickle cell disease. Next slide, please. These are my disclosures, no relevant relationship to disclose. So I was born with sickle cell disease and diagnosed at birth, thank you to newborn screening. And as mentioned, I'm a PhD student studying prevention science that actually starts today. And I really have a yearning for learning patient-reported outcomes, or PROs, for sickle cell disease at Rutgers University. I'm also a mother to a 3-year-old daughter and also a fiance. And that also came with challenges living with sickle cell disease and pregnancy on that journey. Next slide, please. I particularly like the importance of patient-reported outcomes because they directly reported by the patient. This is not interpreted by a clinician or a researcher and really pertains to the patient's health and quality of life. And I think with sickle cell disease, you see me like right now at home, and then you see the flip side of being in the hospital with a crisis or an emergency room. But what we're not talking about or capturing is what happened in the middle. What was the mental health aspect? What did that patient do to try to eliminate going to the hospital? Was it their sleep impacted? Was it their chronic pain? Was it their mental health? And really, patient-reported outcomes can really capture that and tell that patient story while they're at home in between. Next slide, please. So PROs can really be beneficial also during that pediatric and adult transition. We're still seeing a lot of sickle cell warriors have a deterioration of health during that time and a decreased quality of life. And from a previous study that I did at a center in New Jersey, almost half to 100% of 22 to 24-year-olds, they struggle with doing daily activities due to chronic pain. So imagine you have that chronic pain that's not being discussed with your physician or not being captured during research, that can really struggle with going to the grocery store, playing with your child. And 83% of 20-year-olds were depressed about their health. Again, that mental health. Mental health can really affect your physical health. And that's something that we would like to discuss more within the sickle cell community as well. Next slide, please. So we do have a tool and a research tool, and is validated and reliable to measure the physical, the social, and emotional impact of sickle cell disease, which is the ASCME, Adult Sickle Cell Quality of Life Measurement Information System. And that's something that I would like to use within my research within New Jersey and used before. However, I just did a brief look at PubMed. It's not really widely used in research and policy implementation. So if I was to go on Google right now, PubMed, there's not a lot of studies using that ASCME or even being implemented within quality measures. Next slide, please. And particularly, we like that because it's a validated survey for sickle cell disease, right? And it's also capturing emotional well-being, social impacts, sleep, and pain. Even when you're talking to your physician, whether it's your PCP or your hematologist, within that conversation, it's mostly, okay, I saw you're in the hospital. How are you feeling now? Is your pain controlled? It's not really asked mostly, how is your emotional well-being? Do you need to see someone or talk to someone? Socially, are you able to go out with friends? Are you able to play with your children? How's your sleep? We like to call it painsomnia within the sickle cell community. And that can also impact your pain, not just the crises, but also the chronic pain at home. And something that we would like to see is adding that fatigue severity scale. Within the sickle cell disease community, we see fatigue really impeding on our quality of life, whether it's from the medication, the anemia, or a combination of both, really impeding the relationship of fatigue and functioning. Well, I was so fatigued, I wasn't able to go to class. I was so fatigued, I wasn't able to go to work. If we're able to combine those aspects of emotional, social, and sleep, but also improving fatigue severity, we really try to improve quality of life and implement that more in policy and research. And research has shown that improved quality of life is the most common patient treatment goal within the sickle cell community. Next slide, please. So I like to see quality of life as an umbrella from my perspective. Even though that's the most common patient treatment goal, everyone's umbrella may look different within the sickle cell community. So my umbrella would be addressing my chronic pain, able to go to work, go to school, play with my 3-year-old daughter, pain crisis, trying to stay out of the hospital as much as I can, my mental health, making sure my mental health is okay, and the fatigue as well, and organ and bone damage. So again, everyone's umbrella within the community may look different, but I like to see this overarching theme of quality of life and how that may differ from one person to the next. Next slide, please. So I see the sickle cell community as a beautiful community of everyone's different umbrellas. But as we conclude, I would like to see after this improved implementation of validated patient-reported outcome measures, specifically for sickle cell disease. That can be within the clinician setting, that can be within the research setting, within the federal policy setting. And patient-centered research and policies can lead to patient-centered care. If we center the patient voice and center that patient within all realms of care, we will see a lot better improved outcomes within not just research, but also medicine. And patient-reported outcomes, they're more than just a value, they're more just a number or a percentage. They are that patient story. It tells you what happened at school. It tells you what happened at home, and how they see their life continuing within this beautiful community of sickle cell warriors. Next slide, please. So I want to thank you once again for everyone coming. I can't wait to see the other speakers talk about this important measure and outcome. And once again, happy Sickle Cell Awareness Month. Thank you so much.
Thank you very much. I was just talking earlier today that it's a small world. You have to be nice to everyone. And when I saw Mariah Scott's ad from when she was a baby, I was the head of the PT Monk program there at Overlook Hospital way back around the turn of the millennium. So we could probably go and find a paper chart with my terrible handwriting on it with me seeing you. So always good to have a small world. I was neglectful in doing the basic functions of an MC, which is to say that if you need to use the restrooms, you turn out into the main hallway where you came in through security, walk to the other side of the building, and turn left. So just to mention that. And then when we do have a lunch break, HHS rules are that every non-HHS person be escorted. We can escort up to 5 people at a time, so we'll figure that out. But pair up with a CMS buddy or HHS buddy, and we'll get you to the cafeteria on the penthouse floor. So with that, it's my pleasure to introduce 2 speakers. We have Dr. Lynn Shaw, who is a counselor to the secretary, and she will be speaking, as well as Dr. David Wong, who is the senior advisor for sickle cell disease in the Office of the Assistant Secretary of Health within HHS. Previously, Captain Wong chaired the interagency HHS sickle cell disease work group from 2018 to 2020. And I will just highlight that the pediatricians here are taking the lead here in doing this. We're always proud of the pediatric community. So please join us.
Hi, good morning. My name is Lynn Shaw, and I am a counselor at HHS for Secretary Becerra, and I am really here to say thank you and to Dr. Klein and Dr. Hughes and the administrator for holding the session, and also the American Society of Hematologists. We could not really have better partners than you all in this work that we're doing to improve quality of life and health outcomes for individuals with sickle cell disease. I see a few familiar faces, and it's good to be with you in person. For once, Zoom has become a daily part of our existence, for good and for bad. But the wonderful thing about the work that we've been able to do here at HHS on sickle cell disease is that there's just been such a dedication and outpouring. And a lot of that starts with the work that even Dr. Hughes started many, many years ago when she was at HHS, but also has continued on through administration to administration. And Secretary Becerra has really wanted us to invest as many resources as we can into sickle cell disease. As many of you all know, it is an undertreated condition, and the population of individual sickle cell disease, more than 100,000 Americans and others who maybe not be detected, who are maybe coming over through our borders. We just have not invested the number of resources that we want to into this condition, and we are making strides to try and improve those changes now. And I am so excited for us to be doing this work on quality because the population is not as large as maybe our normal Medicare or Medicaid populations. It's just quality measures is just harder work, but it is integral work. It's integral work for us to raise awareness among our providers. It's integral work for us to make sure that individuals who enter emergency rooms get care that they need, get access to pain treatment as quickly as possible. And there is unfortunately still just a lack of understanding, a lack of education, and stigma associated for this patient population. And it is a major priority for the secretary that we figure out how we get our arms around this and address this as quickly as possible. So just wanted to be here to celebrate this with you and thank you for your work and the dedication that you all have shown over decades, and we look forward to continuing this work and making strides. And with that, I want to make sure I turn it over to Dr. Wong and give him the floor. He has been really leading and spearheading a lot of the work across HHS, from the work that we've been doing together with ONC and ASPE on data, and then the work that we're doing within HRSA and NIH and FDA. There's just a lot of room for us to keep collaborating and keep coordinating. And I will just turn it over to Dr. Wong with that. And thank you so much for letting me join you for a bit today.
Great. Thank you, Lynn. It's a pleasure to be here today. As Lynn said, I'm Captain David Wong. I'm a pediatrician and the senior advisor for sickle cell disease and OASH. And previously, I led the similar work group in 2018 to 2020 under Admiral Giroir. So it's great to see many familiar faces here, and appreciate, of course, the collaboration with CMS and American Society of Hematology on this important topic. So next slide, please. What I thought might be helpful for my remarks is just to share at a high level how this work might fit in with the overall HHS vision and portfolio for sickle cell. So I wanted to just share this initial slide. This is something that we shared with our HHS leadership with Admiral Levine and Secretary Becerra about a month after I started. And there was buy-in for this vision. I want to reflect on what was shared by multiple speakers today, including Mariah. You'll see the word thriving in there. This is something that we really wanted to add in terms of addressing quality of life, which is so important. Unfortunately, it's not something that we really addressed at all back in 2018 to 2020. We were working so much on just getting our HHS house in order with all of our different programs focusing on sickle cell with a big S. We need to really think about sickle cell programs with a little s, all the other things that are part of being a sickle cell warrior, really thriving and succeeding in life. We want to make sure that they have all those tools and resources as well. Another thing I want to highlight here on this slide, as far as how we're approaching our work, many of you are familiar with the NASM Sickle Cell Consensus Report that was sponsored by my old office, Office of Minority Health, and OASH. It's a great report. I know many of people still continue to follow it. We use it as well, but it's not the only work that's really guiding what we do. But I want to highlight that in the NASM report, there are 25 recommendations for 8 overarching strategies. And based on my interpretation, 4 of those 25 recommendations have to deal with quality. And that's the highest number of recommendations that report focuses on any given topic. And so just my paraphrase of those recommendations, one of those recommendations is on research, one is on quality measure development, another one is on requiring quality measures, and then there's the 4th recommendation on quality improvement collaboratives, essentially scaling quality measures and indicators so that we can have better successes across the country. And so I just want to say that because it's this committee from NASM, nonpartisan, multidisciplinary committee of experts. They all came down to the conclusion, essentially, that quality is so critical for this population. And then I just want to highlight kind of our 3 overall overarching priorities. And then with the next slide, I'll just walk through very high level. I'll just cherry pick a few things to show for all of you today. So with I think priority number 1 is actually probably the most important thing that we will do, is really ratchet up our engagement with the sickle cell community. And I essentially see this session as part of that work. Some of the other things that we're doing are with a new initiative designed to improve quality of life for warriors called SCD SOAR. And SOAR stands for Services, Opportunities, Activities, and Resources. And essentially, what we're trying to do is have an opportunity every 2 months through this virtual series for warriors to meet new federal agencies, ones that maybe they're not as familiar with, like CMS, like HRSA, but other folks like SAMHSA or HUD that have issues and resources that could really help them. And we want to make sure that they have better access to those experts and better access and understanding of those resources. Our first kickoff session was in August 19th with SAMHSA and Mental Health. We had over 230 attendees, almost 500 registrants, and really positive response because as you heard earlier from Mariah and others, mental health is so critical for the warrior community. And whatever stage of life you're in, it really cuts across the lifespan. And so we want to make sure that folks have access to those resources. Our next SCD source session is scheduled in October, and it'll be with HUD on public housing. I also just want to highlight here, we've been doing a lot of public events over the summer and through the fall. We have for a celebration of National Sickle Cell Awareness Month, the inaugural HHS Sickle Cell Disease Summit, which is going to be on September 24th in this very building, in that empty space in the middle called the Great Hall. And we're really excited about this. Secretary Becerra will be convening the meeting. We're also hopefully going to have some members of Congress. We're going to have approximately 50% of the 30+ speakers will be warriors, families, or advocates. We really want this to be a community event, a community celebration, and hope many of you will be able to come. There will also be a virtual option for live streaming that event as well. Next slide, please. Now with priority number 2, this is where I would say the quality work fits in as well, and a lot of the other kind of sickle cell with the big S kind of programs. But I want to highlight one new initiative that we are thinking about engaging with, which I think is so important, is really strengthening that partnership between the sickle cell community and state Medicaid agencies. And we haven't gotten very far with this, but we realize and know that 50 to 60% of people with sickle cell disease are enrolled in Medicaid, and that there are so many potential resources and advocacy and support that can come from those state Medicaid agencies. How can we work together, federal agencies with the community, to strengthen those partnerships? There's a couple of links here for some ideas that we've shared in previous meetings. Next slide. Again, like this slide deck will be shared with you later. I just gonna cherry pick a few things. But I think on this slide also, I just want to highlight that we're also doing a lot of awareness and education with other agencies outside of HHS. So we've been working with Department of Education, and they released for World Sickle Cell Day on June 19th, a sickle cell disease and a 504 disabilities fact sheet. We're also talking with education about things related to early intervention for children with sickle cell disease. How can we get better uptake of those services across the different states? And we're also looking at things like sickle cell in foster care. You know, what kind of resources, how many children are there in foster care that we can additionally support? So lots of ideas that are coming from these conversations. Next slide. And then priority again 3, I think this quality of life is so critical, as we heard from Mariah and others earlier today. Besides mental health initiative, which we have started to embark on, we're also focusing on reproductive health. There'll be a fireside chat on that topic during the summit on September 24th. And we also are working very closely with the Social Security Administration to improve the evaluation process for both children and adults with sickle cell disease to access disability through SSA. And I think some of you may have seen there was a press release last week that SSA has commissioned the National Academies to do a review of pain management for sickle cell disease as it applies to disability, to help them, you know, have a better evidence base to update and review the disability listing criteria. And I can share also that, you know, SSA is developing some sickle cell specific tools to help families and warriors as they are doing those evaluations for disability, so they'll come as prepared as possible and increase the chance of success that they'll be awarded that disability listing. Next slide, please. I just want to acknowledge as a whole team at HHS working together very closely with CMS and the other optives. Lynn, of course, has been a great champion and leader for us. I also want to highlight Zainab Jama. I don't know if she's here today, but she's with IEA, Intergovernmental and External Affairs. That's the group within the Secretary's office that handles his events, his travel, his engagements, and she's done an amazing job preparing for the summit, as well as many of the other engagement events that are led by IEA. And I don't have them listed here, but ASPA, the Assistant Secretary for Public Affairs, has also been incredibly important partner with our branding as we've been rolling out different products. I'll show a couple slides next. This next slide is just the graphic for SCD SOAR. That's our quality of life series. If we can go to the next slide, please. And then after that, this is an original graphic that Aspen developed for us. And then the next slide is a QR code and a graphic that will hopefully be rolling out today, which is a graphic to promote the summit. And this is inspired by graphics from the signs and placards from the 1963 March on Washington. So if some of you think it looks familiar, it's because of those photos. And we want to essentially evoke that same sense of community and advocacy from the March on Washington, because essentially the sickle cell fight today is really an extension from that civil rights era. So I really appreciate everyone here today for this event. I hope many of you will be able to join our summit on September 24th, as well as many other events that we'll be collaborating on together. So thank you so much, and I'll pass the mic back over to Ron.
Thank you, David. So we are running 5 minutes ahead of schedule. So that's wonderful news. So if you will, now it's time for a break. And if you'll come back a little bit early, about 10:50, we'll get going, and then we'll have hopefully more time to talk if in the afternoon if we stay ahead of schedule. So please stretch, and if you need to go to the 7th floor, grab a HHS friend. Got to follow the rules in their building. Except those of us who are taking a picture. Come on up here. Sitting up here.
Yeah, maybe.
Ron, such a pleasure to meet you. Thanks for coming. Okay. All right. So continue. Good morning, everyone. So we're going to get going. We're going to transition a little bit from sort of broad, opening concepts of caring for people with sickle cell disease to government programs and, what our levers are, what we can do, what we can't do, where the opportunities are, where the challenges are. And that will be, I'll be giving that first talk. And as I said before, my name is Ron Klein. I am a proud pediatric hematologist oncologist in practice for 20 years. I've been in the government for 10 years, 7 of which at CMS and 3 at OPM, Office of Personnel Management, helping guide the Federal Employees Health Benefits Program. So with that, I'll start on sickle cell disease. So opportunities and challenges, no conflict of interest. The government doesn't allow me to own any healthcare stocks. So why does CMS measure quality? And I think this is an important thing. Sometimes people say, well, why are you even doing this? What's your reason for being? And I always like to take a broader view and say, people, when you go shopping on Amazon, you always look for the reviews and you make sure, is the quality of this product I'm going to buy good? If you were to go to a retail store and your products are always being returned to the manufacturer, that retail store would probably find a different manufacturer, to buy that product because quality is important. And I think that healthcare is no different. Federal government spends about $1.5 trillion each year between Medicare, Medicaid, marketplaces, Indian Health Service, everything in terms of paying for healthcare. So it's important that we make sure that Americans are getting the best healthcare possible. So that is the reason for quality measurement. And ideally, I was going to look at that, but that's too small. I go too far. Sorry. All right. So why do we measure things? Well, you can't improve what you can't measure. And so you need to have metrics that allow you to find out just how well you're doing, because if you ask people how well they're doing, they'll say we're doing great. So you need objective measures of that. It's a way to understand performance, and it's a key product of continuous quality improvement. Again, you need to find out where your gaps are. And I think we can link them to payment programs, and I'll talk about that in a moment. And it also creates consumer awareness in terms of picking the best hospitals, the best clinicians, for your care. I worked on the oncology care model for a few years when I was at the Innovation Center, and there were financial incentives for doing well, but also within the practices, there were metrics within the practices as to how well each of the physicians were doing. And if you spoke with the practice leaders, they said that more important than money here or there was how well they were doing compared to their peers. So us doctors are a competitive lot. And if you think you're doing great, but you find out you're at the bottom of the heap, you're going to improve your care. And so just measuring people drives performance, drives improvement. So we have about 500 measures so far in active use. And that is, you can look for that in the CMS measures inventory. It's, I think, cmit.gov. And you can see all the measures that are there, and there are various different filters that are there. And people ask, well, why are there so many measures? Why do you need so many different measures? And I was bored one day, and I went to the American Board of Medical Specialties, and I counted all the different medical specialties that exist, the subspecialties. And this was a few years ago, so there are probably more now, but there were 68 different medical specialties, pediatric surgical specialties. So when we're putting together quality measures, one of the things we need to do is to have measures that are relevant to different people's practices. And so that's part of the reason why there are as many measures as there are. We're trying to make measures digital, which has decreased administrative burden, decreased clinician burden. I'll speak to that a little bit later. And as Mariah Scott spoke about, we're trying to focus on patient-reported outcome measures. We're working on that as well. That's another priority for us. So how do you measure quality? And again, for those of you who are steeped in the quality world, I apologize because this is a quality measurement 101 review. This structure, this context for thinking about quality measures came from Dr. Donna Bedian, who wrote, I think, a seminal paper in 1966, was printed in 1986, and he really was the one who established how we think about quality measurement. And one of the measures we have are what are called structural measures. So those are the attributes or settings in which care is provided. And this includes material, human resources, and organizational structures. So as a simple example, you want to provide critical care to patients. Well, do you have a dedicated ICU? Do you have a dedicated intensivist? Do you have critical care certified nurses? Those are basic structural things that measure quality. We have process measures. So what is actually done in providing and receiving care? It includes both patient and provider activities in making a diagnosis and recommending or implementing treatment. So you're a primary care physician. Are you measuring the hemoglobin A1C in your patients who you think might have diabetes? Are you checking your blood pressure? Are you measuring the BMI? Are you doing all those things? So basic process measures. And then the last one are, what we call outcome measures. And those are the ones I think that we strive to get to. I think those of you, who are physicians or work with physicians, I call it the cranky physician mindset, which is don't tell me how to do my job, just look at how my patients do. And so we try to work towards outcome measures. And of course, when you try to work towards outcome measures, one of the challenges you have with outcome measures is you have to risk adjust. So different people will tell you that, well, my patients are different. My patients are sicker. Sometimes that's not true. Sometimes it is true, especially around academic medical centers. So it's not just a matter of measuring outcome, a very simple, straightforward thing, usually, but where was the starting point? Did this patient with sepsis come into the ER? Were they sicker or were they less sick? And how should that impact how we look at mortality, for instance, as an example with sepsis? So what are the things that make a good measure? We want to have high impact. So obviously we want to measure things that are important. And we want to, have meaningful meaningful to patients and providers. We want to have measures that support and are supported by scientific evidence. So medicine changes, new drugs come out, and we have to make sure that our quality measures keep up with that. No unintended consequences. Those are always the dangerous things in a complicated and fragmented healthcare system across the United States. And how do we make sure that all that works okay? And I always tell people that when we work on quality measurement, it has to work in Manhattan and it has to work in Wyoming. And that's one of the challenges. It has to be valid and reliable. It has to be feasible. It has to be easy to collect. Because if you can't collect the data, you can't have a quality measure. Appropriate risk adjustment, which we just talked about in terms of different people. We're going to have different outcomes based on, what they come in with. Standardized data elements, which we're working on. We're especially working on that with something called FHIR. FHIR, which is FHIR, which is Fast Healthcare Interoperability Resources, which is the next step in digital data and making sure that you have the standardized data elements that are created for everything you want to measure. Low burden. I think we've read a lot about clinician burden, clinician burnout. And the last thing we want to do is make people's lives harder, especially when we'd rather they spend their time taking care of patients as opposed to doing administrative tasks associated with quality measurement. And we talked about outcome is preferred over process measured. Again, just along the lines of I may have a different way of doing things, but my patients do just as well, so let me do it my way. And to a certain extent, that's okay. So CMS National Quality Strategy, the mission to achieve optimal health and well-being for all individuals. And our vision, CMS is a trusted partner in shaping a resilient, high-value American healthcare system that delivers high-quality, safe, and equitable care for all. Here's the CMS National Quality Strategy, and I won't go through all of those in detail, but basically our 8 pillars. Equity is important. We want to make sure that all Americans receive equitable care, and I think we have work to do in that area, but we're making progress. Engagement, we engage with you all, and we meet with people to try to hear from people what their issues are, what their problems are, so we better understand them and can address them. Safety, there was a recent Office of the Inspector General report that I think was 23% of Medicare patients suffer some sort of injury during hospitalization. About half of those are thought to be preventable. So how do we address that issue? Resiliency, we learned a lot about that during the COVID epidemic, and just how narrow some of our, how much little reserve there was in our healthcare system, how difficult supply chains were, the just-in-time inventory management, which was a big thing, in business a couple decades ago. It blows up in your face when your supply chains blow up. Outcomes, again, we talked about that. Alignments, we want to make sure that we're coordinating across program and care settings so that we've worked very hard at CMS with ARC, with CDC, with HRSA to try to make sure that we're measuring things in the same way, again, to help minimize burden. Interoperability, so make all the computer systems work together, and that's important. There are some entities that have private systems that don't want their systems to work with other systems, and that's where the federal government comes in and says, yes, you must work with you must play nicely in the sandbox. And scientific advancement, again, medicine is changing. In oncology, those of you who are hematologists, oncologists know how quickly oncology is changing with genetic measurement, with understanding genetic mechanisms of cancer and other diseases, and so how important it is that our measures keep up with scientific progress. Here are the quality levers that we have. We have payment policy. So it's amazing how much people can change when you determine how much you're going to pay them on that basis. We have conditions of participation, which is what we call a nuclear option. That's how you basically say these are the conditions for you participating in the Medicare program. And if you don't participate, then we won't pay you. We can't participate in the Medicare program. And one of the interesting factoids, little details of life that we talked about the other day is that, what desegregated all hospitals in the United States? It wasn't the Civil Rights Act of 1964, it was Medicare. Medicare said, if your hospitals are segregated, you can't play in the Medicare program. Miraculously, overnight, hospitals became desegregated. We have survey and certification programs. We have quality improvement. We have our coverage and analysis group. So when technologies, new medicines come out, we look to whether they're appropriate to cover. The FDA's mantra is safe and effective. CMS is reasonable and necessary. So just because a medicine is FDA approved doesn't necessarily mean that Medicare will cover it. CMS will cover it, but so it's part of it as reasonable and necessary. Clinician engagement with the quality measures, which we're going to talk about more today, value-based programs, and again, the stakeholder engagement. So these are 27 different CMS programs that measure quality. The ones that are in red connote pay for performance, and the ones that are not in red are pay for reporting. So basically, if it's in red, your payment is tied to the outcome on that measure. If it's not in red, it just means you have to report it. Now, I will say, sort of going back to what I said before, that that hospitals are very aware of their public image and what we call the care compare system. What you may know is that the Medicare star system and how many stars different hospitals and acute care facilities get and chronic care facilities, and people are very, very aware of that. And so even though it's only pay for reporting, that does affect people's behavior. So here's getting down to brass tacks. Here are our quality measures, here are data sources for quality measures. So as I said before, you can't measure something if you don't have the data. So where do we get the data from? So there's manual data abstraction from the patient record. That's obviously the highest burden, administrative burden, which basically means going through the chart and saying, well, when did, in the case of our sepsis measure, the current one that we're working to update, when did that patient get antibiotics? When were the blood cultures drawn? When were these various lab tests drawn? We have claims-based measures, which are relatively easy from our claims-based system, but claims are limited. The information is limited to date, clinician, facility, and the ICD-10 and CPT codes. And it doesn't always contain sufficient clinical information, excuse me, to give us the data we need. So one of my pet peeves as an oncologist is we have ICD-10 codes for, we can tell you what quadrant of what breast a woman has breast cancer in. But we can't tell you if she's HER2 positive or negative, if she's triple negative, if she's estrogen receptor, progesterone receptor positive. So we are limited in what the ICD-10 system can give us. So we're therefore limited in what we can do with claims. And sometimes we have to use indirect inference to try to do things from claims. So if you had this disease, then you must have gotten A and B, which we can measure. So if you didn't have A and B, then you don't have that disease. If you got A, you have this. If you get B, you have that. But if you get both, you have that. So we do that a lot of times, like for instance, in oncology, where somebody will say, well, if you have this, since we don't have the stage of the disease in claims, we'll say, well, if you had this stage of disease, you would have gotten this chemotherapy, part B chemotherapy, and we can see that in claims. So again, it's a little bit difficult. We'll see what ICD-11 brings whenever that comes around, but that is the challenge of working with claims. We have immunization registries, which I think are all in 50 states. We have clinical quality measures, CQMs, which aren't necessarily electronically specified. We have ECQMs, which I'm going to talk about a little bit more later, which the ASH sickle cell measure leverages, and that's really important, where all of the data that we have is pulled from the EHR, pulled from the electronic health record, so the clinician burden is decreased. We have the Social Security Death Index, so when we have outcomes of mortality, 30-day mortality, we have that from the Social Security Death Index. This is a paper from July of last year that came out of Hopkins, and one of the interesting things, and I don't expect you to be able to read that graph, but basically it looked at the costs associated with manually abstracted measures versus digital measures versus claims measures. And once you've created your computer systems to get the data, the ongoing cost of a digital measure is about 1/15 to 1/20 of its chart abstracted measure. So one of the things you may have heard or will continue to hear is that a CMS goes forward with quality measurement. Our strong focus is on digital quality measurement. And I always say that sort of my personal vision for the future of quality measurement is that clinicians just do their job, taking care of patients, which is what we're supposed to do, and that the EHR and everything else just collects that seamlessly without any additional burden. We're not there yet, but that's where we're working towards. Medicare, I think you all know this. So, Part A is inpatient coverage, Part B is outpatient coverage, Part C is Medicare Advantage, which sort of bundles together A, B, and D. And sometimes additional additional services, that is, runs through a prior authorization kind of system, which you may or may not like. And then there's Part D, which is prescription drug coverage. So those are the different parts of Medicare that we can leverage to do different things in terms of quality measurement. Medicaid, and Deirdre Stockman is going to speak more about this, so I apologize if I'm not exactly precise, but she will correct my errors. It's a joint federal and state program. Those of you who love history, like as I do, 1964, when they were negotiating Medicare, the Republicans wanted a state-based program, the Democrats wanted a federal program, and so the compromise was Medicare was federal and Medicaid was state. Federal government funds about 70% of the Medicaid programs, but they're primarily state-based institutions. And so that creates challenges because that means we have 50 or 51, 52 different Medicaid programs. Each of them are somewhat different. And so how we make those all work together to do quality measurement. The nice thing about that is that oral prescription drugs are covered by Medicaid, which they aren't necessarily in Medicare unless you also have Part D as in dog, Part D coverage. Why is that important? So we looked at this the other day, or maybe a year ago or so, and we said, well, you know, a great quality measure would be, can we see in the Medicare program patients with sickle cell disease get hydroxyurea? You know, tremendous step forward in terms of dealing with pain crises. And we can, if you have Medicare, if you also have Part D, which again, about 80% of Medicare patients do. But again, those are the limitations of trying to work with what we have. So you've heard this a few times. There's 100,000 patients with sickle cell disease that we're aware of. We think about half have Medicaid, and about 10% have Medicare. About half of the Medicare patients are dual eligible, so they're both Medicare and Medicaid. And the geographic distribution in the United States varies widely. And here's a picture from the National Academy's report on sickle cell disease. I call this both an opportunity and a challenge. So it's a challenge because when you look at national programs that we want to roll out, and again, Deirdre is going to speak to this later in terms of Medicare, Medicaid core measure set, you can't do those if they can't have a core measure set in a core measure in a measure set program if there aren't patients for the states to report. And so you see there are some parts of the United States that don't have a lot of sickle cell patients. But there are very few states, 5, 6, 7, where the bulk of sickle cell patients are. So the opportunity there is you don't have to roll out a program for 50 states. You can roll it out for 7 states and achieve a lot of what you want to achieve by doing that. So I'm going to focus just lastly in closing. I think this is a successful example of a sickle cell disease quality measure that was brought to us by ASH a few months ago. And it's a time to receipt of pain medications for sickle cell disease patients with vaso-occlusive crisis. Originally it was for adults only, but the pediatricians in the room pounded their fists, and now it includes people of all ages, kids of all ages, so that's important. It's a clinical meaningful measure. So it identifies a gap, which is how quickly can we get pain medication to people who are in pain. It's all ages, as I mentioned. It's a definitive objective measure of success. So there's no argument. Patient, came in the door, at this time, they got their dose of medication at this time. And here's the part that I really like. As we sort of struggle with how many sickle cell patients have Medicare, how many have Medicaid, what state, what an ECQM is, at least for us in the inpatient quality reporting program, is it's an all-payer program. So regardless of the type of insurance you have, commercial insurance, Medicaid, Medicare, whatever, you come in and that is measured and reported to CMS. Now, we only adjust the payments based on, we only adjust Medicare payments, not commercial insurance. We obviously don't have authority to do that. But it sort of helps get around the issue of how do we capture information on patients who don't have Medicare or Medicaid. So this is what you call an ECQM, and it's a really wonderful way to do that. And I think that's one of the reasons that we're supportive of this measure. And the last point is that the information is contained within a single facility, so you don't have to depend on interoperability of data to make things move forward. And very difficult when you have your transcranial Doppler in this this private radiology facility, and then they come into the ER, which is a different hospital. And how do you, at this point, we're still working on interoperability, but how do you make sure that data gets seamlessly transferred? So the nice thing about this quality measure is that it's a single, all the information is contained within a single facility. So goals for today, final slide. What are our quality gaps in sickle cell disease that we can feasibly measure given the challenges of data sources, the various different programs, statutory limitations we have. They should be clinically meaningful with objective data. They should capture quality that identifies a significant part of the patient population. We really want digital information sources. We don't want chart abstracted measures. And we don't want to, at this point in time, we'd rather not be dependent on interoperable data, meaning information shared with different sources, because I don't think we're quite there yet, although we're moving forward. And with that, I'm happy to stop and go on to the next presentation. Thank you very much. I think I have 5 minutes. Does anybody have any questions? Sorry. Yeah. I'll repeat the question. Go ahead. Mhm.
Right overall,
Mhm.
the one concern is, I noticed it doesn't say parental pain medications, so thank you. It does not say parental pain medications, and so we don't want folks staying in the ED in the waiting room getting a dose of oral pain
Yep.
medications, because that would defeat the purpose. And then my other, when we talk about unintended consequences, right? I'm in this new place. There are 115 centers in the National Alliance for Sickle Cell Centers, all of which have medical directors who fight every day for every resource that we have. And now currently in Philadelphia, multiple large clinical centers. What is it there from my center saying, it's lovely having you here, but we would rather have the patients with sickle cell disease get their care across town and let them worry about the quality measure. And so I worry about the unintended consequences where we want to motivate institutions and incentivize them to do the right thing and provide resources to accomplish these goals. We don't want them to say, you know what, it's all nice, but we don't want you to attract 600 adults with sickle cell disease because our emergency room is already packed full. And so how do we address that potential unintended consequence that they say, you know what, we'll only take care of 20 adults, the rest will go across town.
Well, thank you for the first question. So the first question was what came up immediately as we started to talk about this measure. And certainly we don't want a bowl of Motrin sitting out in the ER waiting room and everybody grabs some Motrin and you've done your job. So the plan is to stratify based on oral and parenteral pain medications. So that is one way to address that. It could just be parenteral, but some patients just get oral. Yeah, well, then it's going to be, so getting a dose of Motrin, as you walk in the door does not count. That would address your first question. Second question is more complicated. I don't know how you as a hospital that's funded by the government, probably state and federal and local, say, you person with sickle cell disease, don't come here. I don't know how you turn people away, so I'm not sure I understood your question. Mm-hmm.
But we hope that patients will go to the emergency room associated with their sickle cell.
Yes.
Right? But if the institution says, I don't really want to have a sickle cell program because we don't want to attract patients to our emergency department, not that in your, establishment high quality sickle cell care, we'd rather, the institution across town, they can invest in their sickle cell program and the patients will all go there for their emergency.
Okay. Well, that's a big question. Let's leave that for the discussion, but that's certainly a good question. I'm going to stop right now before I go over time and introduce Dr. Deirdre Stockman, who is the Director of the Division of Quality and Health Outcomes in the Center for Medicaid and CHIP Services at CMS. Deirdre.
Thanks, Ron. When you started talking about history earlier, I thought you were going to talk about 1789 or even before when the project of federalism was started, because we think about federalism every day in running the Medicaid and CHIP programs. And that's a fun part of my job. But another great part of my job is the opportunity to come and learn from people with lived experience and people who are expert in things that I am not expert in, and then to have the opportunity to work in community and collaboration with you all to figure out how we can improve care and outcomes for people, for some of the 80 million people who are enrolled in Medicaid and the Children's Health Insurance Program. So I'm really glad to be here to have that opportunity to learn from you and to think together about how we can better measure quality of care for people with sickle cell disease, including those who are covered by Medicaid. And again, the Children's Health Insurance Program, which I will usually refer to as CHIP, C-H-I-P. I did a webinar recently and someone said every single time C-H-I-P, but we say CHIP. So I think as Ron, or maybe it was Dr. Wong earlier noted, about half of the people nationwide who are affected by sickle cell disease are enrolled in Medicaid or CHIP. So the Medicaid and CHIP programs have a key role to play in assuring that all of those individuals have access to the quality of healthcare they need, the right time, in the right place, in the right setting, in a person-centered and equitable way. And as CMS is committed to improving access, quality, and experience of care for individuals living with sickle cell disease. And we know there's a lot of room for improvement. So for example, data show gaps in recommended care, I think has been mentioned, for Medicaid and CHIP beneficiaries with sickle cell disease, specifically in rates of transcranial Doppler ultrasound screening and pneumococcal vaccination for children, and in rates of hydroxyurea use among children and adults. In 2017, 78% of people with sickle cell disease who were enrolled in Medicaid or CHIP had an emergency department visit, and 49% had at least one inpatient hospital stay. These data points are drawn from an analysis we conducted a few years ago. It was on somewhat old data, 2017. We are planning on doing some updating soon, but we conducted analysis a few years ago of Medicaid and CHIP TMSIS data, we call it, to learn more about individuals with sickle cell disease who are enrolled in our programs and to really better understand access of care and quality of care and health outcomes for those folks. So we're here today because quality measures and monitoring quality data are central to the project of improving care and advancing equity. Standardized quality measures help us to identify variations in care, to see where improvement is needed, and my favorite part, to point us to bright spots and help find best practices where things are working well and what we can help to scale and spread. And that's something that we focus a lot on in the Medicaid and CHIP quality measurement and improvement program. So when it comes to Medicaid or to quality measurement in Medicaid and CHIP, there's a lot of attention to our Medicaid and CHIP child and adult core sets because they're the national quality measure sets for our programs. And the only measure sets at CMS, I think, are one of just a few that don't actually sit in the Center for Clinical Standards and Quality with Dora, but they sit in the Center for Medicaid and CHIP Services in close partnership with our friends at CCSQ. And a key point, though, I want to make today is that the child and adult core sets are not the only way that quality of care is measured in the Medicaid and CHIP programs. Again, federalism, state-based program, lots of different approaches to measuring quality in state Medicaid and CHIP agencies. And I'll talk a little bit more about that. But if you want to zone out, that's my key point. And I'm going to give a little color to it in the rest of my remarks. So for background, I'll share a little bit more about the core measure sets and then talk about some of those other levels of measurement within Medicaid and CHIP that I think are viable and important in our conversation today around quality measurement related to sickle cell disease. So the purpose of the Medicaid and CHIP core sets is to provide a national picture of the quality of care delivered by the Medicaid and CHIP programs. The core sets are unique sets of quality measures in that they are reported at the state level. So other CMS quality reporting that Ron nicely summarized earlier happens at lots of different levels: clinician, provider, facility, hospital, health plan, and others. So measures for those programs are designed and specified at those levels. And of course, CMS has lots of programs, as Dora mentioned, to develop measures to meet all of those program needs. For the core sets, the measures have to be rolled up to create state level rates. And there are a few ways that states do this, either aggregating health plan rates if they are a state that delivers most of their services through managed care programs and plans, or by analyzing the data directly at the state level and developing a state rate. So for measures to be suitable for the core set, they need to be feasible for state level reporting. And one of the criteria for consideration and inclusion in the core sets is that the measure has been tested and or used at a state level and by a state Medicaid program. Additionally, given the national purpose of the core sets, CMS only reports publicly measures that are reported by or that we have data from at least 25 states. Because in order to call something a national rate, CMS determined we need to have at least 25 state rates to combine. So in order to develop that state median, what we call a national number, we need a minimum of 25 states. And this is a challenge. This is a real challenge for measurement of conditions that affect groups that are small relative to the population of 80 million people in Medicaid and CHIP. In many states, denominators for measures of conditions like sickle cell disease are too small to report at the state level. Which makes them unfortunately not a great fit for the Medicaid and CHIP core sets. But I'm going to get to some of those other levels of measurement in just a moment. So I do want to mention that CMS, the Medicaid and CHIP through Medicaid and CHIP Child Quality Program, through a partnership with the Administration for Healthcare Research and Quality, or ARC, funded the development of a few quality measures, which I'm sure many of you are familiar with, for children with sickle cell disease, which were developed by the University of Michigan several years ago through our funding. But only a handful of states are able to report those measures to CMS because they have large enough populations in the denominator. However, those measures are available for use by Medicaid and CHIP programs at lots of different levels, health plan level or within states that do have large enough populations. So while those measures aren't appropriate for the core sets because we can't publish the data publicly, CMS is really thrilled that they're available for use by Medicaid and CHIP agencies, health plans, and providers. And a handful of states we think are using those measures. I think we have some, I can give details on them, but I won't try to speak them all now. Which brings me back to that key point. So every state runs its own Medicaid and CHIP program within federal guidelines. They all have quality programs. Every state Medicaid and CHIP agency has a quality program. And they have the flexibility to determine what are the right measures, what are the areas of focus that we need to emphasize in our Medicaid and CHIP programs, where are we trying to drive improvements in quality, and develop programs around that, and identify measures and to have reported to the state by providers and health plans in order to track at the state level, depending on the needs of their state populations. And so in those programs, states track many measures that are not core set measures. They track many core set measures and many other measures that they draw from various sources, including HEDIS, from the Core Quality Measures Collaborative, or CQMC, where those two University of Michigan developed and stewarded measures for STD for children are included, as well as many other sources. So I think in closing, I want to emphasize that the Center for Medicaid and CHIP Services is excited about this opportunity to work with you all today to develop, to identify where we need to start developing more measures to fill gaps in quality for care for people with STD. And then CMCS, Center for Medicaid and CHIP Services, will continue to work with CCSQ, with HRSA, with other partners at HHS to make sure that those measures are available to, known about, and used in state Medicaid and CHIP agencies at the appropriate levels. Lots of opportunities, I think, for us to promote, support measure development, help folks find measures that make sense for use in their programs so that they can be, best tracking, understanding, and ultimately, of course, improving the quality of care delivered to Medicaid and CHIP beneficiaries. So thank you. I'll stop there. I may have time for questions. 5 minutes for questions. Happy to address questions.
Hi, good morning. Kathleen Hewitt with American Society for Hematology. Could you talk a little bit about some of the data sources that were presented earlier? ASH has a national registry, which has about 60 institutions across the US that are participating in submitting data with electronic health record data. And we're going through data validations. I saw reference to National Death Index and other data sources. So could you talk a little bit about the availability of those data sources and the mechanisms for national registry programs to get access to that?
Sure. I'll start a little bit from the Medicaid and CHIP perspective and then see if Dr. Klein wants to fill in any more on the Medicare or other perspectives on data sources. So I think in the Medicaid and CHIP quality measurement space is very much in line with what Ron described, before me around that the way that quality measurement is moving is trying to draw from all of the data sources where the good information about quality lives. So I often say, we kind of reversed engineered quality measures to use claims data because those were the data we have, but those data tell us what we paid for, but not what we got, right? And so we want to be, and the field is very much moving towards drawing from other sources like registries, electronic health records. So I personally am just learning about that registry and I'm glad to know about it. And want to work to definitely include those data in future quality measures. With the caveat, as Ron noted, the healthcare system, including Medicaid and CHIP programs and providers, is still on the journey to be able to consistently extract data from multiple different sources. I think that is where the field is moving. That's where the puck is going. That's the kind of measures we need to be developing and then supporting our Medicaid and CHIP programs, plans, and providers, as well as all the rest of the plans and providers in the health system. They're a lot of the same people, of course, to be able to use those rich data where the best information on quality of care actually lives. And that includes, of course, patient-reported outcomes data as well, which I think is, we heard about this morning, so important in this space. And that we need to consider from a quality measurement perspective is how do we harness that information in a standardized way across settings, across payers, across healthcare delivery systems in order to really represent the experience of care and the quality of care as holistically as we can, as completely as we can. Anything else you want to add to that? Yeah.
Hi, thank you. I'm Jennifer Bright. I'm the CEO for the International Consortium for Health Outcomes Measurement. And you just used the word standardize again. So here's my question. I'm also a student of federalism, so I know the variability that exists in the Medicaid data sources. If outcomes is really the next horizon and to focus on that, what's the appetite for standardization truly? Because, I've heard a lot of words bandied about, but we're still focused on process measures largely over outcomes. And so what's the appetite for actually putting some things down in the name of trying to get to more standardized and outcomes focused measures?
Can you just tell me what you mean by putting some things down?
Like stop measuring some of the process things that we
stop.
measure.
So stop expending our
But
energy.
let's call it
energy on-
rebalancing, because
Okay,
I know
got
that
it.
when I say ditch
We
it,
know rebalancing
Yeah.
in Medicaid. Okay. That's right. So what is the appetite for moving away from process measures to more outcome? I think there's a huge appetite for it, but the standardization piece is key. So if the outcomes are living in a bunch of different health records that, despite many efforts over the last couple of decades, are supposed to be standardized but aren't quite. I see some nods, like you're right. In order to extract, especially, from my perspective, as I said, when we're trying to collect state level measures, have to be able to get all of that data out of all of those different health records or all of those different emergent registries, has to be standardized in a way to do that electronically, right? Because we just don't have the resources and staff to be looking at, Medicaid programs, health plans, providers don't. Ron doesn't want to spend time going back through charts, right? You want to deliver care, have it live in your data system, and have it be able to be pulled out electronically without lots of human effort. And so that's where we need standardization. So less in claims that tell us about processes and, again, what we paid for, but not what we got. But how can we be standardizing the other more rich sources of quality data in a way that we can get it out? I mean, that's what keeps me up at night. So if anyone has any answers to that, come tell all of us. Thank you.
More fruit for the discussion this afternoon. So I'll just answer two real quick questions before I introduce the next speaker. So there are what are called QCDR, Qualified Clinical Data Registries, and those QCDRs do develop measures and are incorporated into CMS quality measurement programs, particularly the MIPS program for measurement. So there is space for that. As you're talking about looking at outcome measures, and I harken back to what I said before about how do you risk adjust. So in this world that we're talking about with sickle cell disease, there's SS, there's SC, there's SD, there's S beta plus thal, there's S beta zero thal. And all of those patients who have sickle cell disease, if you will, have different outcomes, obviously overlapping outcomes, but different outcomes based on that. So when we talk about risk adjustment for sickle cell disease so that we can risk adjust for outcome measures, how do we capture the data at that level of detail so that we're being fair to everyone? So that's just something for you to think about as we, in preparation for our discussion this afternoon. The next speaker is Debbie Sarkar, and she is the Deputy Director of the Division of Services for Children with Special Health Needs at HRSA. And she does not have slides, so she's just going to be gracing us with her presence and her talk. There you go.
Good morning or afternoon, everyone. Thank you so much for letting HRSA be a part of this meeting. We're really excited to be here. I apologize that I don't have approved slides to share, but I was a Girl Scout when I was little, so I have a backup plan here. And as soon as they are approved, we will send them out. So today I'm going to be talking about the challenges within the system of care for people with sickle cell disease. But before I get into that, the first thing I wanted to do was, I know many of you know about what HRSA funds, about our TDP programs and our FP programs, but you might be wondering, why does HRSA think the way they do? Why are they asking grantees to do specific things? And so what I wanted to briefly go over first is what we have is our Blueprint for Change for Children and Youth with Special Healthcare Needs. And this blueprint is a framework that lets, over the next 10 years, can help improve the system of care for all children and youth with special health needs and their families. And it's a massive document. It's got like 40 or 50 objectives. But what I want to highlight here is that the blueprint has 4 core focus areas, and they are access to care, quality of life and well-being, financing of services, and then health equity. And with those 4 focus areas, we have our vision, which is we want to make sure that families have what they need so that their child can play, go to school, and become a healthy adult. All right. The blueprint also talks about when it comes to quality measures and data, it has 3 specific activities for us to do. And one of them is measuring what matters across the whole population. The second one is analyzing the data and disaggregating the data to help improve equity. And then the last thing is we use that data to improve outcomes through a continuous quality improvement strategy. All right, so I don't have the slide, but what we did is we used the blueprint and we mapped out what the system of care would look like for patients with sickle cell disease. So we start with newborn screening. Every baby in the US is screened for sickle cell in every state and territory. So they're going to get diagnosed and then they're going to go through the system. They're going to access, community-based supports. There's having a medical home with a specialist. There's, following all the clinical guidelines. Then we get to early intervention, transition, and what we hope to get after going through all the steps is that we have children and adults thriving, doing well. What I just described, though, is very linear, right? It's step by step process. Say you're a parent and you just find out that your baby has sickle cell disease. Well, that path forward is not clear at all. And when you start, every child is unique with sickle cell. You start learning what your child needs and trying to figure out like where to go and get those services, it becomes even more unclear and it becomes a maze. And so here at HRSA, what we're looking at is it's our job to help these families get through the system. While we're trying to help families, we all know this, but it's worth, me saying this out loud. There are so many challenges that impact the system of care, right? There are so many barriers for families and adults to access, evidence-based care, community, supports. And
it's been said already this morning, you know, kids are not getting, you know, just routine work that they need done. We have families and individuals that live far away from comprehensive treatment centers. They can't access the care there. When we're talking about transition from pediatric systems to adult systems, we are losing young adults in the follow-up. And then I'm channeling Sophie here. If there is a family that's interested in transition, there aren't enough adult providers, you know, that are trained to give sickle cell care. So, and then with all of these challenges, on top of all of this, we have this persistent, you know, discrimination and social determinants of health that negatively impact, you know, folks that are living with sickle cell every day. So what are we doing about those challenges? So I'm sure all of you are well aware of our sickle cell treatment demonstration program, and then our sickle cell newborn screening and follow-up program. Our first program, the TDP program, they get about $6 million, and there are 5 regional grantees, and their goal is to build comprehensive sickle cell care teams and expand the reach of their teams through collaboration with clinics and practices in at least 7 different states. And they use like a hub and spoke kind of model to coordinate care and treatment for patients with sickle cell. And then with our newborn screening follow-up program, we fund 25 community-based organizations, and this is the first cycle that we're giving funding directly to CBOs, and they are there to ensure that families are connected to services, and they work with our TDP grantees as well. They also leverage the expertise of community health workers. And then the third part of our portfolio is that we have a hemoglobinopathies National Coordinating Center, and they provide support to our grantees, and they have a CHW training program as well. Then I had a fancy map showing you where the grantees are and where all the clinical sites are, so you'll see that later. This meeting, today's meeting, I think comes at a really great time for us because we are working with our grantees and with CDC and with CMS and Dr. Wong, and we're looking at quality of life measures. We're at the very, very beginning of this, so we're looking at clinical measures, and then we're also looking at measures that families find important. So I'm making this up, but it could be around kindergarten readiness or high school graduation. But we're starting to think about it and what would a series of quality of life measures look like in the sickle cell community. So excited to be here at this meeting and to hear more from you. And the last thing, I went over a whole bunch of challenges and barriers. I wanted to end on a positive note. We also have a newborn screening portfolio that we fund. And the state of Connecticut has done something, I think, innovative. They have 2 hospitals. It's Yale and Connecticut Children's, and where any baby that has an out-of-range newborn screening result is referred to those 2 hospitals. And what the state did is that I'm not a tech person, but they took Epic's health maintenance tool and they put in all of the sickle cell guidelines into that tool. And now the EHRs at Yale and Connecticut Children's is pulling out this data based on the guidelines that they put in. And at a clinician level, you can see, okay, my patient's coming in, they need X, Y, and Z. There's a dashboard at the clinic level. You can see what all the patients are, how well they're doing. And then the state has a dashboard. So all babies that were diagnosed with sickle cell, they can see where they are. Are they, getting the services? Are they meeting milestones? So for us, that is innovative. Can this be replicated in other states like New York, Texas, California? Probably not, but it is a starting point, I think. So I think that's the end of my talk. I was pretty fast. So happy to take questions. Oh, and I also wanted to just say, we have here with me our sickle cell team, Mandy David, Alicia Keene, and Christiane Novoa. They know way more than I do, so can help answer questions.
You have like 5 minutes if you want to take a question.
Sure.
Thank you. So before I introduce our last speaker before lunch, I wanted to just point out, we're seeing a lot of questions in the chat and various things. So those of you who are attending virtually, we are not ignoring you. We're saving up your questions and chat for the afternoon. So we will get to you at that point. So the man standing between us and lunch is Dr. Robert Liam, and he is the chair of ASH's Clinical Practice Guidelines on sickle cell disease, and he's a member of the ASH Committee on Quality and a participant of the ASH Learning Community. He's head of the Division of Hematology, Oncology, Neuro-Oncology, and Stem Cell Transplant, and director of the Center for Cancer and Blood Disorders at the Ann and Robert H. Lurie Children's Hospital of Chicago. He's also professor of the Department of Pediatrics at Northwestern University, Feinberg School of Medicine. Thank you.
Thank you, Dr. Klein, for that introduction. So as a representative for ASH today, the American Society of Hematology, I've been tasked with really talking about all of the terrific, important initiatives that have been led and sponsored by the American Society of Hematology around guidelines, education, their efforts around education and training, helping more institutions develop adult sickle cell centers, their research priorities, as well as helping to launch a research collaborative and a learning community. But before I do that, I do want to take a few minutes to talk about this concept of the comprehensive care model in sickle cell disease, why that's so important and why that's a theme that weaves through all of the initiatives through ASH. So this slide just illustrates the framework that we continue to rely on for the work that we do in improving the lives of individuals living with sickle cell disease. This is a multi-level framework that requires partnerships and collaborations at the federal level, the institutional and organizational level, programmatic and team levels, and then collaborations with important community-based organizations and professional societies like ASH. The end goal, however, throughout all of this is to be able to improve the lives of people living with sickle cell disease through a model of care that's considered comprehensive and high quality. The federal government has had a long-standing commitment to addressing sickle cell disease ever since it passed the 1972 National Sickle Cell Anemia Control Act, which was the first major piece of legislation to address education, screening, testing, counseling, as well as research for sickle cell disease. This work has continued now through another important piece of bipartisan legislation called the Sickle Cell Disease Comprehensive Care Act that aims to ensure that individuals with sickle cell disease have better access to comprehensive, high-quality care that encompasses not just important clinical aspects, but also the recommended services for mental health, ancillary, and support services. I just also wanted to say that ASH remains a very, very important advocate in these efforts, again, to help develop initiatives through education, training, research, to help align programs with this comprehensive care model. So I do want to just take a few minutes to talk about why we still need comprehensive care in sickle cell disease. I've listed here a number of different factors that, again, help us to realize that we still need comprehensive care because these factors really continue to negatively impact outcomes, including morbidity and mortality for people living with sickle cell disease. So I don't think that I have to really explain to the audience or many of you online, but that we still continue to have evidence and struggle with poor access to care for children and adults living with sickle cell disease. There continues to be inadequate knowledge about sickle cell disease among different providers. There's lack of awareness of guidelines and standards of care or best practices around the management of people living with sickle cell disease. And of course, we've already talked about some of the suboptimal transition programs and practices that, again, negatively impact outcomes for this population. All of this continues to have a negative impact on acute care utilization and healthcare costs, as well as negatively impact outcomes for this population, and continues to contribute to high morbidity and mortality in this population. And then lastly, I think that all of us recognize, as a prior speaker had already mentioned, that we need to continue to evaluate the role of social influencers of health, as well as evaluate our understanding of structural racism that intertwines and weaves through all of these different factors that impact our ability to provide comprehensive care for this population. So when we talk about comprehensive care in sickle cell disease, what do we mean? And I think the easiest way to do this is to think about the essential components, the ideal components, and then other components that enhance this model of care that is what we consider comprehensive and high quality. So of course, the essential characteristics include access to sickle cell disease specialists, as well as specific nursing staff that have expertise and experience in sickle cell disease, but also a multidisciplinary approach that includes team members in social work, in patient care navigation, as well as in care management. We also think that it's important to have ancillary care services to help provide expertise for transfusion services, for mental health, and then also subspecialties. Oftentimes, not only do our patients require access to a good subspecialist with expertise in sickle cell disease, but because of the end organ damage that we see over the lifespan of our patients, they need good access to subspecialists and other specialties like pulmonary medicine, cardiology, neurology, and others. What's also essential for a comprehensive care program is also this adoption of treatment guidelines and best practices around disease-modifying therapies like hydroxyurea, as well as understanding of the preventive care services that are required for this patient population, especially in the pediatric population. And then, as Dr. Fasibe will talk about more in her talk, this understanding that we need guidelines and treatment protocols in urgent care and emergency department settings where many of our patients seek acute care services. What constitutes ideal characteristics for comprehensive care is having an infusion center and a day hospital so that our patients can avoid having to go to the emergency department. There have been many studies and data to suggest that this approach is not only cost effective, but improves the quality of life for our patients with sickle cell disease. Transition program services are important and ideal for a comprehensive care program. Mental health services, educational career services, as well as access to neurocognitive specialists or neuropsychology is also very, very important. And then much of our discussion for the next 5 to 10 years is going to be around treatments with the intention to cure this disease. And so access to stem cell transplant doctors are also very, very important. And then finally, especially for pediatric population and for adults of childbearing age, genetic counseling services and access to reproductive resources is also very, very important. So I'm going to switch gears now and talk a little bit about all of the important and essential sickle cell disease initiatives that have been launched by and led by and developed by ASH. And so this slide provides a high-level summary of all of these different initiatives around quality care and helping to facilitate research. And so some of my subsequent slides will highlight some of these initiatives. I also want to just highlight the fact that a lot of these initiatives around sickle cell disease by ASH also center on global issues as well as advocacy issues in helping to shape policy for sickle cell disease, including ASH's launching of the Sickle Cell Disease Coalition, which is an alliance of stakeholder organizations out there, which now has over 100 members. So one of the most important efforts and initiatives for ASH in helping to improve clinical care for patients living with sickle cell disease was the development of the clinical practice guidelines, an effort that started in 2016. So to date, ASH has published 5 different clinical practice guidelines around cardiopulmonary and kidney disease, around cerebral vascular disease, transfusion support, stem cell transplantation, and management of acute and chronic pain. I'm also happy to say that in the next couple of years, we hope to be publishing a 6th clinical practice guideline around the use of hydroxyurea dosing and management. ASH is currently in the process of putting together the expert panel for that guideline. Even though it's important to publish these guidelines, it's even more important to disseminate and implement these guidelines. And so ASH has put a lot of effort into the dissemination and implementation of these clinical practice guidelines through development of educational materials such as teaching slides, pocket guides, as well as other toolkits. ASH has also been instrumental in developing and putting together committees that have worked on developing shared decision making tools, one on transplant that I'll talk about in the next slide. And as Dr. Fasife is going to be talking about a little bit later, leading a committee based on looking at quality measurements and the development of measurements specifically for pain medication delivery in the emergency setting. So ASH's transplant decision tool is really an important tool that they developed in collaboration with the Mayo Clinic Shared Decision Making National Resource Center. As all of us know, the decision to undergo transplant can be a complex one to navigate for not only providers, but also patients and their families. And so the transplant decision tool helps to support clinicians in guiding their patients through this complex decision-making process, as well as offers a structured framework to discuss the individual clinical decisions, values, as well as preferences for this treatment. I'm also going to pivot a little bit and talk about some of the educational and training efforts that have been led by and sponsored by ASH. These are really, to me, very, very remarkable and addresses the shortages of providers out there with expertise and experience in treating patients with sickle cell disease. So one of the most important initiatives that's been sponsored by ASH has been the development of a hematology-focused fellowship training program. So these are training programs that are focused on training what we consider classical hematologists, including expertise in sickle cell disease. And since 2022, there have been a number of different institutions that have now instituted this ASH-sponsored fellowship training program. Since 2022, ASH has also sponsored an away rotation or elective for 2nd year and 3rd year fellows who are interested in learning a little bit more about sickle cell disease. So this is a really, really terrific program. And then also in 2022, ASH launched a 3-series podcast that includes interviews with sickle cell experts discussing sort of the past, the present, and the future of sickle cell disease. And then I think what's coming soon and what's really, really needed is education and training around treatments with the intention to cure. So with the FDA approval of gene therapy. Besides helping to address the shortages in workforce for sickle cell disease, ASH has also sponsored a very important workshop that's centered on helping institutions build an adults comprehensive sickle cell center and building this network. And so since May of this year. They just hosted their 5th workshop around this. The workshop really aims to help institutions develop a business plan, to advocate for important stakeholders, as well as helping them to understand how do you measure impact of related to developing an adult sickle cell comprehensive program. And so since May of 2024, they've had their 5th workshop, and they've added 10 new institutions and hospitals to this program, now totaling up to about almost 60 institutions across the US and Canada. So lastly, I'm going to just pivot a little bit and talk about some of the efforts by ASH to facilitate research for sickle cell disease. So this year, ASH has just revisited their list of research priorities that you can see there, some of which have been around for about a decade. The ones that have been around for a while include enhancing pain research, developing novel therapies, strengthening curative therapies, enhancing pain research, and investing in sickle cell disease trait. Sickle cell trait research. And then what you can see here in the blue are the newest research topics that ASH is sponsoring, and which was developed from consensus from a number of sickle cell experts in our field. And these include assessment, prevention, and treatment of end organ dysfunction in sickle cell disease, optimizing the use of hydroxyurea, blood transfusions, and other disease-modifying therapies that are currently approved, looking at the impact of dissemination and implementation of evidence-based guidelines for sickle cell disease, and cross-cutting themes that including looking at management of patients with sickle cell disease in low and middle income countries, as well as reproductive health for sickle cell disease. And then finally, I'm going to just talk for a few minutes on the Research Collaborative, which is a really important initiative that, again, was launched by ASH as a way to address the lack of high-quality evidence that's out there to inform clinical decision-making for providers taking care of patients with sickle cell disease. So the Research Collaborative, one of the most important aspects of it is the Data Hub, which is a centralized, multi-level, real-world data registry or repository that's based on electronic health data. And it helps to facilitate sharing of clinical data to serve many different purposes, including scientific discovery. So these data are being used currently to exchange ideas and to look at factors such as clinical outcomes, clinical practice patterns, as well as to identify opportunities for quality improvement work. The Research Data Hub is also here to really help to facilitate research by helping institutions identify cohorts that may qualify for important clinical trials as well. Given the reach of ASH and the number of members with expertise and experience in sickle cell disease, it also made sense for ASH to develop a learning community, which is a way for institutions and experts to really share ideas around standard practices, standard operating practices, best care management strategies, and things like that. And so currently the learning community through ASH is focused on applying quality improvement methodologies to really look at 2 key areas, including how to improve the use of and the uptake of disease-modifying therapies, as well as co-developed pain action plans. The newest effort brings all of these sites together to start to look at implementing and developing transition from pediatric to adult-based care practices, and what everybody's experiences around that might be. So with that, I just wanted to thank everybody for giving me the opportunity to promote all of these important initiatives for ASH around taking care of people with sickle cell disease. I think ASH really represents just one piece of the puzzle and relies on these important collaborations with HHS and HRSA and CMS and our other partners in order to help, importantly, to improve the lives of people living with sickle cell disease. Thank you very much.
Thank you, everyone. So we have a 1 p.m. break, and I apologize if this feels like kindergarten, because it really does. Will everybody who's here from HHS raise your hand? CMS or HHS? Okay. So technically, the rules of the building are that an HHS employee escort no more than 5 people to lunch. I don't know how well it's going to work out, but I'm on record as saying that I tried. The cafeteria is on the 7th floor, so you come out here, you go up, you take the elevator right to the penthouse, and we will see you at 1 o'clock, and then we get to get into the discussion of things. So CMS, HHS, people raise your hand and escort people. Thank you. Welcome back from lunch. I think we lost about half our people. So, okay, we're going to keep it. Okay. So we're going to keep this on time. So welcome back from lunch. And hopefully more people will make it down from the cafeteria. So a last speaker before we start sort of open discussion will be Dr. Fasipe again, who I introduced previously. We thought that she flew in this morning from Houston, which accounted for being a few minutes late, but we were wrong. She underestimated Washington, D.C.'s notorious traffic and thought that certainly 3 miles could be done in an hour, but that she was so. But anyway, we're glad that she's here. Lesson that I've learned many times in my life. Anyway, so Dr. Fasipe is representing the American Society of Hematology. As a side note, ASH, it's always fun. We had a lot of confusion in the government. Can explain to people that ASH was the American Society of Hematology, not Office of the Assistant Secretary for Health. So we had to keep clarifying those ASHs, that ASH acronym. And she serves in integral roles in leadership on ASH's technical expert panel, developing sickle cell disease quality measures, including the one I mentioned about the time to treatment. She's a member of the ASH Committee on Practice, and she is chair of the ASH Research Collaborative on Sickle Cell Disease Sickle Cell Disease National Community Advisory Board. She's also co-director of Texas Children's Sickle Cell Disease and Thalassemia Program, an assistant professor of pediatrics and hematology oncology. So she's going to talk a little bit about some of the sickle cell disease measures that ASH has worked on, and then we'll go from that we'll have a small break, and then we'll go directly to discussion. And by the way, I'm not rushing home, so we technically end at 3, but if the conversation is great, we can keep going. It'll take you 5 minutes to get to that.
Thank you again, Dr. Klein. Hope that's audio is good. So I have to first thank CMS one more time, in addition to all the federal partners, HRSA, and the various sister agencies as well. The work to address the challenges of sickle cell disease started decades ago. You heard this throughout some of the talks today, and each of those areas and progression cycles, if you will, they were pushed by a wave of advocacy. And so we have agencies looking at the biology and the particular pathophysiology of the disease. We have those that are focused on the access to equitable care, as you heard, drug approvals and development. And then, of course, what brought us here today and brings us here today is the discussion on quality. And so I want to give another plug for the podcast that was alluded to earlier today that kind of goes through some of the history of these waves of change and progress for sickle cell disease. And I hope you'll be able to have a fuller view. And then I also want to thank Ash. Dr. Liam gave this wonderful presentation of the work that has been going on. And this work has been a culmination of almost 10 years of figuring out how to prioritize sickle cell disease and all the various aspects of what that looks like. And so I thank you also for Ash for supporting me through my journey as a pediatric hematologist, but then also for that sickle cell disease emphasis on the affected persons. And then I also want to say a thank you to a group that you do not see in the room, but they are on the Health Services Advisory Group, not only for their support with this presentation, but also the work that went into trying to make a sickle cell disease measure. And so we're going to talk a little bit more about that today. I don't have any relevant disclosures. However, I mentioned earlier, I'm a pediatric hematologist and I am an affected individual. I feel like this work takes a lot of different lenses, and those are the two that I bring, and with that, maybe some of my own biases. So our objectives today, we're going to review the landscape and strategies for quality measurement for individuals with sickle cell disease. And we're going to highlight recently developed measures that focus on acute pain, which you heard mention a few of the presentations ago. And then we're going to discuss evidence-based interventions to improve care for individuals with sickle cell disease related to clinical interventions, increasing access to care, and addressing social drivers of health. So first, when we were trying to look at the various wide landscape of sickle cell disease quality measures, we implemented the CMS Measures Inventory tool. We also looked at the consensus-based entity submission tool and repository. And then we also looked at measures that through a prior environmental scan. And that led us to 22 fully developed measures that were specific to patients with sickle cell disease. Most of these measures are pediatric in nature. In fact, all but one, and this one is the new one that we're going to discuss today, reflects the adult population. So there's a gap within itself. 20 of these are process measures, and 2 of them do focus on experience of care. And then the 3 that are supported by consensus-based entity that are endorsed include transcranial Doppler, as well as antibiotic prophylaxis and hydroxyurea use, again, pediatric population. So the one ASH measure that is being considered currently by CMS through the for hospital outpatient quality reporting, you'll see the acronyms up there, and then rural agents emergency hospital quality reporting programs. We're very excited that we have made it this far. So if we take a little bit of a deeper dive into looking at these measures, you'll see that the majority of them, so the blue part of the pie graph, are facility measures. And these are measures that you have to abstract from the medical record or from surveys. And they include one electronic clinical quality measure, which we'll discuss. The 14% that is in the reddish color, those are health plan level measures. And you can see that they are the 3 that I already alluded to, that are the ones that are supported by the consensus-based entity. And then they also are claims-based. And Dr. Klein gave a wonderful overview of the differences of how we get data. And then that last 14%, the one in the green, is for the state level. State level is also claims-based, but you can also take medical record data as well. And you'll see that those emphasize antibiotic prophylaxis, as well as the confirmation testing that's required for newborn screening. How efficiently are babies confirmed their sickle cell diagnosis after the screen has gotten them. And so the goal is, of course, for alignment, as Dr. Klein mentioned earlier, but that's what our landscape starts with. So when you ask patients what is important to them, well, from a 2021 survey that ASH performed with HSAG, we looked at individual responses, and 14 respondents that are patients with sickle cell disease, as well as 6 caregivers. every person was asked which aspects of healthcare could be improved upon and what is the most meaningful of that. And you can see from the patient feedback that they emphasized prompt emergency care and wait times, the issues associated with the delays to care. What does it mean to assess and evaluate somebody with sickle cell disease? What happens after a hospitalization? And then that transition piece from pediatric to adult care. They also brought up mental health as an important driver for them, as well as what does it look like for the healthcare system to be accountable? And how do you regulate that? And then, of course, most heartbreakingly is the stigma. Most of them, of course, emphasizing how they have been associated or called a drug seeker. And then also the communication that occurs between a patient and their healthcare providers, whether that's the doctors or the nurses that interact with their care. And then just listening. They wanted people to listen to them. When you look at what clinicians value as important, we've clustered these into 5 major categories: preventive care, screening, medication therapy, care coordination, and utilization. And you'll see that the ones with the stars, and I know that's a little bit tiny, but the stars are those that with the asterisks are those that are already reflected in a measure that we discussed earlier. And you'll see that, not all of these are feasible, right, for a quality measure. However, you can still think about making them amenable to a quality improvement intervention. I want to highlight a few that stood out to me. For instance, under preventive care, annual comprehensive visit at a sickle cell disease program. That's something my institution is trying to work on. And then screening, neurocognitive tests, it's quite important when you think about education and vocational success. And then also utilization, where a lot of institutions put their focus on when it comes to cost of providing care for individuals with sickle cell disease. So what are our gaps? And we are going to take this part of the presentation to evaluate areas that we find might be the biggest and lowest hanging fruit. So from a standpoint of looking at process measures, and I will get to outcome measures too, but for process measures, we evaluated not only what the patients and clinicians told us, but we also looked at the guidelines that exist for sickle cell disease and which ones came with strong recommendations. And so they overlap in 4 spaces: hydroxyurea prescribing in adults. As we mentioned, there is already a measure for children, and then neurocognitive screening and evaluation in adults, as well as screening and evaluation for developmental delay and neurodevelopmental disorders in children, and then vaccination against streptococcus and pneumonia. And so these are ripe for the picking for new development. Now, just to emphasize the gaps a little further, how wide are these gaps? It's pretty wide. So in 2021, Medicaid and CHIP released a sickle cell disease report that I'm sure many of you are aware of that looked at the analysis of 2017, the year 2017 data. And it found that only 1/3 of beneficiaries with Medicaid were on hydroxyurea, and even less percentages of those were on it more than 180 days in a year. And then when you look at the side of pneumococcal vaccination, 6 in 10 had one on record of a pneumococcal vaccine, but 40% didn't have any documented at all. So quite an important gap to look at when we're thinking about these process measures. So what about outcome measures? For potential outcome measures, we think about how does one experience care? And I loved Mariah's presentation earlier, how she got the ball rolling today. Utilization is there. So how often are you frequenting the emergency department, length of stay, a readmission, inpatient cost? And then frequency of how your sickle cell interrupts your life. So whether that's vaso-occlusive episodes, the amount of time you need blood transfusions, and then the all-important patient-reported outcomes. And kudos to her for making that part of her studies. I'm excited to learn more about her work. And then the key lab values could also be considered. And this is an interesting idea because it almost merges 2 worlds. So can we look at biomarkers of hemolysis? In the age of gene therapy, can we measure that as an outcome as well? How robust were the therapies? And so there are lots of room for outcome measures there. And so what about measures that already exist in the general population that we can maybe leverage or adjust for sickle cell? Well, already exist measures looking at unplanned hospital readmissions. Immunizations are also important to the general population. And then the consumer assessment of healthcare providers and systems has several questions related to bias on how you are managed with your health condition, so disability, age, culture, all those things. So these are areas that we see that overlap between the general population and sickle cell disease. So to recap, some of what we have said, and then also to kind of emphasize the challenges. One of the questions that were brought up earlier today, sickle cell is a big problem to try to attempt to solve. So first, it is considered a rare disease in the United States. We are saying that it affects about 100,000 individuals. Those numbers come from 2010, and so we're grateful for efforts such as those with the CDC trying to get us closer to the real number, but it is a rare disease. It's a common disease, but a rare one. And so the sample sizes can be small. So what are potential solutions to that? Well, you might need longer measurement periods to capture what you're trying to see. And then you would probably need a measure at every single level, whether that's facility, health plan, and state level accountability. And then you might have to stratify a little bit to dive deep. And so even if there's existing things that we consider important, how do we slice out sickle cell in that, knowing that it's a rare disease? Then the second challenge is individuals with sickle cell disease, they're not uniformly distributed. Dr. Klein showed you the map, and it's kind of quite striking how some states represent the large majority, the lion's share of sickle cell disease. And so thinking about making measures voluntary in nature and that the facilities and states can report, and those that have the adequate sample sizes will be more reflective of how we can improve care. And then because of that rare disease nature, there is limited evidence. Even in the guidelines that exist for sickle cell, you'll see there are several that are strong recommendations, little evidence, moderate evidence. And so this is a challenge, it is. But the goal would be to focus on developing outcome measures and process measures that at least have that strong guideline support, because at least experts weighed in based off of their experience. Okay, so in summary, the strategies for sickle cell disease quality measurement include developing new measures. And so that includes process measures that have guideline support, as we said, outcome measures that are important to the community and relate to sickle cell specific care. And then you can selectively expand the patient population as appropriate. So for instance, we already have a measure for hydroxyurea in children. Let's see how we do on the adult side. And then aligning the certain measures to different levels of accountability. So whether that's state, facility, health plan, and stratifying measures that are used in the general population and slicing out the sickle cell population in that. Okay, so we're not going to address these questions now, but for our next session on the open discussion, 2 questions that we would like to be pondered. 1, are there any measure concepts that should be prioritized for further development? And 2, what levels of accountability should be prioritized for measurement? Clinician groups, facilities, state. Okay. So now let's dive deeper into this measure. And I want to give another shout out to HSAG and to all the ASH team for allowing this to be possible. This work started in 2021, and when I first got the invitation to be part of it, it was like a dream come true. I was nominated by one of my mentors. I got onto this panel. It's called a technical expert panel. So I felt very important. And then we got to work, and the work was challenging. I'm privileged now to be the chair of this group, and it's been a multi-year process. So thank you for hearing our tale. So the background is that pain won, right? When we asked patients what matters to them, pain was like number 1. How they experience care from the healthcare system when they're in pain, especially in the emergency department. And, we're hematologists, so to knock into the door of the emergency room, that was a challenge in of itself. but we felt that we needed to be respectful of the community that we asked the questions to. And so we actually not did one, we did two measures. One of them is still being tested and refined, but we are going to discuss the median time to pain medication for patients with a diagnosis of sickle cell disease in a vaso-occlusive episode. And then also trying to understand that equity question more. We wanted to see the difference of median times to pain medication between patients with a diagnosis of sickle cell versus somebody who has renal colic, for instance. CMS is considering that first measure. And as I mentioned, this is through the hospital outpatient quality reporting, as well as the rural emergency hospital quality reporting programs. So a little bit more about the measure. Some questions were asked about it today. We will have time in the discussion if there's still questions, but I already mentioned the description. The median time is in minutes, and it's from the moment you enter the emergency department to the initial administration of pain medication for all patients, regardless of age. We first started with adults, but we did expand it for children, and then with a principal encounter of sickle cell disease with a VOE. So we have our target population, and because of that rare disease nature, we expanded our measurement time to increase volume. We did it for 2 years. And then we also thought about what was a qualifying medication, and can talk about that a little bit more in the discussion. So this type of score is a continuous one, and the interpretation is that the better quality, it's equal to a lower score, and a lower score is fewer minutes between your arrival time and pain administration. As I mentioned, this is an emergency department level measure. So this is that facility level. And we thought it was important, of course, to include the emergency community. And so we are grateful for the partnership of American College of Emergency Physicians on this. And to give you just another sneak peek, one of our representatives was an emergency physician who had experience with sickle cell, but one represented, I would say, the everyman, if you will, every man and woman of emergency department care who does not necessarily have an expressed interest in sickle cell disease, but interacts with the patients on a regular basis. So our measure, the criteria, we felt, and we knew that we wanted to get an A+ or A at least on this. And so we wanted to make sure we meet all the consensus-based entity measure evaluation criteria on how to make this actually a truly high-quality measure. And so the importance, we wanted to make sure it was supported by evidence-based guidelines and ample room for improvement. So something that wasn't already fixed, like 90% score. And we knew that this was one area that was quite stark. And then the variation in performance, knowing that different facilities might have different response times. Is this feasible? That was an important question. And then, of course, scientific acceptability, including whether it was reliable. And this was quite reliable with the correlation coefficient, of 0.96. So, and just to give you an idea, the consensus-based entity, their minimum is 0.6, or their goal is 0.6. So we were really excited about that. So what about the equitable components? Yes, this is one part in the quest of finding a measure to address equity. It's just a piece of it, but it was quite an important one. And then we also made sure use and usability was something that would be applicable to a wide variety of institutions. And so it being an electronic quality, a clinical quality measure was quite important, as Dr. Klein mentioned earlier. Okay, make sure I didn't leave out anything. Here's what some of the public comments had to say. We were nervous when we released this. It was, we're like, how are people gonna like it? So we released it for a test run and say, hey, what do people think about this measure? This is before we submitted it for CMS. And it was overwhelmingly positive. This was my first experience in this, so I didn't know what would be considered good. We had 85% supportive comments. Most of them were positive. We did have several questions of concern, similar to what Dr. Lanscron brought up earlier today, of unintended consequences. And to give you an idea of some of the comments, the North Carolina Governor's Council on Sickle Cell Syndrome strongly encouraged CMS to adopt this measure to help relieve patient suffering. We had one that we considered like one of our comments that gave us the most pride. This is the one best specific, measurable, achievable, and feasible QI in sickle cell disease right now. And then introducing a quality measure for the expectation of timely analgesia can reduce disparities in care. And brilliant, should be fully operationalized within EMR and brings welcome attention to sickle cell disease pain. And congratulations. So thank you to those that submitted the comments. And it was a mixed crowd, but it was good to see that we had this support. So with this, our last topic, we're going to look at evidence-based interventions to improve care. And so I'm going to cover those that are clinically focused, those that are to improve access to care, and also those that relate to social determinants of health. So the ones related to clinically focused interventions, this includes, and I'm going to have the struggle of the glasses thing. So this includes individualized care plans to inform emergency department care during pain crises, consideration of order sets to standardize pain management approaches, and also clinical decision support tools to improve sickle cell disease management in primary care and other specialty care. And our references are at the end of this slide, but this is, again, from the evidence, individuals that have done the work and seen what works in sickle cell disease space. For the access to care component, we wanted to make sure that evidence-based interventions are co-located care delivery models to support transition from pediatric to adult care, as well as telemedicine improved pain outcomes. And more on the access to care, including care coordination and multidisciplinary care support for fewer emergency department visits, fewer readmission rates, and then also treatment in an infusion center, reducing the time to first dose of pain medication and the probability that a visit ends in a hospitalization. And so these are things that are from the data of researchers and clinicians working in the sickle cell space of what works. When it comes to social drivers of health, the HHS team and HRSA team emphasize this. We would recommend things that are health literacy support services that can help with that goal of fewer hospitalizations and increase the adherence to scheduled outpatient visits. And then, of course, thinking about transportation and translation services to enable improved access as well. So I think, yes, I will stop here. The two main places I will point for those that have questions that are, for instance, are not able to be addressed today or something that percolates later for you, I'll direct you to our ASH team at quality@hematology.org, and then also the HSAG team at measuretesting@hsag.com. And I want to say thank you again to HSAG, to ASH, to CMS, and to all the federal partners. And thank you for those that are listening virtually as well. Very happy to be here, and thank you. So we added another question for discussion in addition to the two that I discussed earlier. The third one says, what opportunities are there for federal partners to collaborate to increase adoption of evidence-based interventions to improve care for individuals with sickle cell disease? And I think especially with the question that was raised earlier by Dr. Lanscron, how do we operationalize these quality measures and efforts? What does it look like for that day-to-day care? So thank you all again. And I think, oh yeah, we'll stop there. Is there another slide after? Okay, I can go past our references real quick. Okay, there we go.
Well, we're running a little bit ahead of schedule. So rather than giving a 10-minute break, since we literally just came back from lunch half an hour ago, I thought maybe what we do, you want to get back to Liam up here? And what I thought we might do would be to start the discussion and maybe go for half an hour and then take a 10-minute break after that, if that's okay with everyone. And although Dr. Liam and I are going to be up here, we are facilitating the conversation, not answering questions necessarily. So please, we want this to be an open-ended conversation that we've sort of been working all day to get to this point. And what I'll maybe try to do is alternate questions from the audience with questions from the chat, so we can sort of make sure we get both folks. I'm happy to stand. Please. Sorry. Oh, no, we're good. I'm good standing. So we get two microphones. All right. So maybe is there a question for the audience, sir? Let's go to give you a mic. We have microphone runners here. Wonderful Ash people. Microphones are right there. Is that right? And we'll try to repeat you, but that gentleman.
Hello?
Okay, right, he's right there.
Hello?
Hello, Derek Robertson, the Maryland Sickle Cell Disease Association. TT, is there a standard measure of when patients should get their first dose in the ER, whether or not that's met or not? And if there is a standard, who sets that? And yeah.
Okay, great question. So is there a standard? The standards that we have are laid by guidelines. The first in 2014, NIH, NHLBI, along with experts in sickle cell disease and individuals from the impacted population. Their first recommendation was you want 60 minutes between arrival time and your dose of medication. ASH in the second, so about 5 years later, there were some ASH guidelines released that focused on acute pain and chronic pain. And they dove a little bit deeper into pain management, but also that consensus-based discussion agreed on that importance of 60-minute time. There are also some guidelines that say 30 minutes between triage and pain. But from that arrival time to dose of medication, 60 minutes is the goal, 60 minutes or less. This is also correlated with labeling sickle cell disease, the recommendation to say you are ESI level 2, so Emergency Severity Index. I hope I got that acronym right. Emergency Severity Index of a 2 or higher. So treat sickle cell as an emergency, and the pain management, the goals should be within an hour. When we were thinking about, maybe I should stop there. When we were thinking about the measures, we were trying to figure out a way to respect the fact that emergency departments are busy places. And depending on what city you are, you can see a variety of wait times. And so with the first measure just being the median time, are we hitting the goal of the 60 minutes based off of the guidelines? But the second one and other ones that we've been thinking about is that equitable, because the individuals from the community are describing that stigma and the fact that they feel that they're being treated differently. And so thinking about how to capture that part of the equation was also important.
I was just going to go ahead and add that, there are probably some of our patients who still feel like 60 minutes isn't fast enough. And so when you think about, the systems that are in place to get these patients in from the time they arrive into the emergency department to the time that they get their first dose of parenteral or IV opioids, 60 minutes is probably the most feasible for what we think about at the pediatric and adult level. Having a systems level component in place to label them as having a severity index high enough so that they get triaged quickly is very, very important, and something that a lot of institutions don't even really have. So that was the only thing I was going to add.
Great, thank you. And I would just add, I think the idea of renal colic is a wonderful idea, in terms of it's a leveling thing, is it really that you can't get pain medications to people quickly because you're understaffed, or is it really because you're treating different people differently? So I think that's a wonderful idea. Working in a pediatric ER in Baltimore, I can certainly tell you that, during the seasons, there are different seasons. So during, fall and winter, when people are sick and the ERs are jammed, that's going to be a tougher, goal to achieve. And during summertime, when everybody's playing outside until they break their bones and come in the evening, that's an easier one to achieve. So, all right. So, from the chat, question? I'm sorry, did anybody else want to, I'm sorry, I want to make this inclusive. Anybody from the audience have any other thoughts? Okay, question in the chat.
Sure. So we're gonna go to Tasha Lee. She said, can you share thoughts on CMS leveraging AI for quality improvements and quality measures, particularly in relation to clinical notes in the EHR rather than ICD-10 and CPT codes to help reduce clinician burden?
Yeah, I mean, I so my sarcastic response, and I apologize for that, is that, whenever there's a problem now in the last year, regardless of the clinical field, it's AI is going to fix it for us. And so, I think we have to be realistic in what AI is going to do. I think it's going to take a while. I mean, having said that, I think AI has tremendous potential. I think maybe what the person is referring to is natural language processing, or NLP, and how we take narrative notes and translate them into quality measures. And I think that has tremendous potential. I hope we get there at one point. We have cross-cutting initiative, cross-agency working group within CMS working on AI to try to stay ahead of the curve and how you do that. And a whole other issue which comes up with AI, right, is that it's a black box. So how do you validate an AI system? How do you make sure it's high quality? Who bears liability if the AI system is wrong? So all of those things remain to be worked out, but I think there's a tremendous potential, but I don't think it's going to fix every problem.
Yes, I think there's probably a lot of interest and research that is sort of focusing on the use of AI and natural language processing. Even when I think of some of my colleagues who've done work in looking at not only the electronic health record, but also, the data warehouses that are associated with their institutions, it can be difficult just to even identify and categorize patients as having sickle cell disease versus sickle cell traits. So even using NLP to look for notes that can help you better understand and put into context measurement of quality metrics can be difficult if you can't identify the right patients. And that for us as a project was even difficult with our own EDW at my own institution. And so I think that there are a lot of barriers, not that they couldn't be overcome, but just as you said, Dr. Klein, I think it's going to take many more years to really tweak that approach and to operationalize that in the first place.
Anyone from the audience want to chime in?
Hi, thank you. This is such a fascinating conversation. I guess my question is, it is important, it's such an important thing to measure the rapidity with which people are actually getting the treatment they need. But had you thought at all about dovetailing that measure with like a pain scale measure or something that's more patient-reported outcome focused, because ultimately you don't want the facility to just meet the 60-minute timeline. You also want to know that the patient's need for pain reduction was actually met. So conceivably, I'm not suggesting anybody's gaming the system, but conceivably it could work where the timeline is met, but the pain is not mitigated, right? And so have you thought about dovetailing two metrics that ought to be, one is the process and the other is the outcome?
Thank you. I will start by saying that gaming is the word. So that was, no. So our biggest critiques were similar to Dr. Lanskron's question earlier, including from CMS. They were worried, okay, so if I give somebody Tylenol in 20 minutes, I check the box, like what would that look like to, maybe not intentionally game the system, but to say that I met the metric, but maybe lowballing it. So this is what led to the concept of that stratification that was brought up earlier. We're going to stratify by whether it's parental medication, so IV versus those that are given orally. This is, I would say, the first step, and we hope in the right direction. It does not address every single problem in that puzzle. In fact, we were hoping for our second measure, which is more targeting that equitable piece. We wanted to make sure these are electronic quality measures. You can get them from the EHR. That was highly important. And then all the other evaluation criteria we wanted to make sure were met. When it comes to that outcomes piece, I think we're going to also have to think more broadly as well. So not only complementary or maybe secondary follow-up measures that can be associated with this one, but just distinct ones in of themselves. So I'll stop there, but I feel like we're only scratching at the surface, but for the fact that there was no measure for adults and trying to tackle one that had to do with pain, that in and of itself, to make sure that it was actually something that could be measured in a universal fashion was our first step.
Yeah, I was just going to add that that was an outstanding question because many institutions from just a analgesia management standpoint have guidelines around patient-reported outcomes and asking patients whether or not they've gotten relief from their opioids or from their pain medication. Because as we know, many of our patients might require more than one dose of pain medication. And so a lot of guidelines stipulate that ideally, you should be asking patients within 15 to 30 minutes of the administration of the first dose whether or not they've had relief, because some patients might come in and they may get their first dose of medication, but depending on whether or not they'd been on oral medications for several days beforehand, may not get the adequate dose. And so may still be feeling a lot of pain and suffering. And so, yes, ideally, it'd be nice to tie a second quality metric related to asking patients about, and documenting pain, whether it's a pain scale or other ways of assessing pain relief in these patients. That's equally important. I think we have to start somewhere and start with making sure that they get their first dose of medication quickly. It also goes to show you why I think there's a lot of effort, especially on the pediatric, I'm sure on the adult side as well, to have patients understand how they should develop personalized pain action plans so that they can either demonstrate or show emergency department physicians, what they normally require and what type of medication that they require. I think that those are all really important steps.
Yeah,
Sorry.
go ahead.
Yeah, so I have a couple of comments. So one is I remain really concerned about including oral because when I reached out in my new institution and I said, oh, these are the guidelines, they said, oh, the orals, we can start with orals. And I said, no, the guidelines specifically say parenteral. And so I think right with this, that will be the easy answer is to give something in the waiting room that's oral. The other thing is, that the time to first dose, very important, obviously from a patient standpoint, but very little data that says that it decreases the risk of admissions. And so, but however, when you compare it to the infusion clinic, right, that time, I think there's more to just getting the time to first dose to improve your outcomes, right? These again are process measures, but right, having an infusion clinic decreased admissions and improved time to first dose, all those good things that we would like to have happen. And so I think we have to be thoughtful about this not being the end all, that yes, patients should get pain meds as quickly as possible, but I don't think it's the final piece. Yeah. And as part of that large PCORI study we did develop along with the community of patient satisfaction with pain management within the infusion clinic and within the ED, and saw that it was improved in infusion clinics over EDs. But that tool, which hasn't been published in PubMed, is being validated. But if you look at the PCORI report we had to complete, we did validate that tool. It's like a 5-measure tool that could potentially be used to evaluate the quality as a patient-reported outcome.
Please rest easy. I guarantee you that having a jar of Motrin, with the MA, doing vitals will not meet the measures.
The other complicating factor is going to be intranasal form
Yeah,
of medications, because we know that a barrier to first IV dose is vascular access for a lot of our patients. And so at least at our institution and others, people are starting to introduce intranasal opioids as a way, as kind of a bridge to that first dose. And that might complicate the measurement as well.
Yeah, and I could see that, intranasal. Again, the point that, to make it clear, the point will be giving somebody a dose of Motrin on the way in the door will not qualify as meeting the measure. Intranasal is an interesting perspective, and I think that, just talking off the cuff, I think that probably is a reasonable way to address that, especially in children where vascular access is difficult. The only thing I'll say in terms of patient-reported outcomes, I think those are wonderful ideas. Mariah Scott spoke to that. CMS has said that we think problems are very important. What we're dealing with now, and there was CMS put out an RFI in the physician fee schedule, proposed physician fee schedule a few months ago, was asking the PROMS community how you want us to go forward in terms of creating a uniform system of both IT structure, PROM structure, not making them all proprietary. So there is a tool called Promise, developed by the NIH, and now I think Northwestern, perhaps somebody in Chicago. I thought Illinois runs Promise for the government, and it's basically their non-proprietary quality measures and pro PMs. So we have already sort of put out there publicly, if you will, messaging, for lack of a better way of putting it, that, letting the PROMS system develop the way quality measurement developed and EMRs developed, which is everybody doing their own thing. At the end of the day, we can't share data. It's probably not going to work with the federal government. And so we're trying to move forward with that. But so to your point, yes, PROMs are really important, making sure people get better. And basically, we're trying to do a little prophylactic guidance here in terms of, PROMs community. This is not the opportunity for you to create proprietary measures that lock everyone out. This is the opportunity for you to work together. So we said that. Somebody else?
I just wanted to add another comment to the concern about how do you have a quality measure, but then impact the approach to how the measure is. This also requires education. Something that we didn't touch on in depth was when the guidelines were released, a subset of ASH team working with American College of Emergency Physicians developed a emergency room version of the guidelines for pain management, and it's a point of care tool. But this takes a large amount of education. It was quite informative to hear the side of a emergency room physician, emergency department physician who sickle cell was not their everyday bread and butter, but they felt that they had a version of sickle cell. And I'm going to call it the boogeyman version of sickle cell. And so how do we educate what it is what does it mean to have sickle cell disease in addition to the guidelines? And so the first thing on this point of care tool, medications are on there, rapid assessment, all of that is on there. But the very first button and thing on the point of care tool is communication. Communication, that listening piece, that understanding what it looks like to have sickle cell pain and how to erase or help dampen the boogeyman version of sickle cell disease. Where would a term like drug seeker come from? So I think a measure is one of those pieces of the pot, but then educating the medical community also about sickle cell disease and having that patient experience be woven in and the concept of outcome and measures as well. So, but I will say there was a strategic reason why we expanded all of the medications and not just the IV ones. And we did include things like intranasal fentanyl and also oral medications. I think we were also trying to show American College of Emergency Physicians that we understand why some of that stereotyping occurs with sickle cell, but how to also broaden the conversation to that of compassion. A person with sickle cell disease should not have to struggle to get medication when you compare it to another person also arriving for pain management. So anyway, we can go on and on about that point, but just know that the quality measures is just one piece. We have to also have an education piece.
Do you have another question or a comment on this one particularly? Because if not,
Slightly different.
let me go to the chat then, and I'll come back to you. So is there a question from the chat?
So, Mary Houlihan from CDC, I wonder if there is thought about how the collection of data about SCD quality measures will lead to improved care outcomes. I imagine there are further steps needed beyond the implementation of the measure and collection of data in order to see the desired results. Are there examples of ways that the implementation of non-SCD quality measures have resulted in improvements in tangible outcomes?
Sure, sepsis being one of them. So just in terms of getting into the federal, weeds, if you will. So our inpatient quality reporting program is pay for reporting. So you get scored, if you will, regardless of how well you do. That is part of our STAR system. So if you do particularly poorly, that will affect your STARS rating. After a year or two, we're allowed to move that to what we call HVBP, Hospital Value-Based Purchasing, and that is a pay for performance measure. So yes, by moving those to, by just creating the measures, and making them publicly reported, we create attention. By moving them payment, we create even more attention. And sepsis is one that is particularly near and dear to my heart as a pediatric oncologist, but also something I work with, for CMS, is we have what's called the SEP1 measure. And the SEP1 measure was in the inpatient quality reporting program and got a fair bit of attention. And beginning of 2024, we moved it to payment. Boy, did it get even more attention. So yeah, there are, really, and that's just one small example. So there are multiple ideas where when you attach either public reporting or money to something, all of a sudden people start to pay attention. So yeah, I think there's tremendous opportunity with quality measures. And that was sort of one of my first slides, was how do you have to measure things, and then you have to use them, report them, pay by them to sort of drive improvement. So yes, most definitely.
I interpreted the question also to sort of have us discuss this. I think somebody earlier in the symposium had discussed the need to think culturally in a shift from process measures to outcome measures. And I think, Dr. Lance Cron also talked a little bit about the fact that, we don't have necessarily the data to support that, time to first medication or shorter time to first medication reduces pain hospitalizations. It's a complicated subject because I would like for us to think that, we're always looking at outcome measures like reduction in hospitalizations or reduced, length of hospitalization, length of stay. Those factors can be really complicated to interpret sometimes in and of themselves. And then when we look at even, patients who are discharged after, let's say they get their first dose of medication faster, or their second dose faster, and then they get discharged and they aren't hospitalized. Just what does it mean from a patient-reported outcome standpoint as far as patient experience, as well as even things like missed number of days of school or missed number of days of work at home. So there's so many outcome measures that we need to think about that are tied to process measures. I think it's most important. I would think for us to look at this important process measure and then think about later on having the tools in place to be able to extract the data that we need to look at the outcome measures.
Let me jump in real quickly. We have HSAG on the line. They are the measure developer for this. If they wanted to speak to that at all, it's a continuous variable. So I assume, the quicker you get the medicines on board, the better, but I'll let HSAG speak to that. If you guys want to take them off mute, if they'd like to speak to it.
I think Kyle or Kendra might be there. Okay.
Yeah, this is Kyle Campbell from HSAG. Yeah, I think as everyone has said, the focus with this measure on really focusing on something that was feasible and electronically measurable in the emergency departments was really important, and kind of moving more towards outcome measurement after we can see the results of this initial measurement is the way we've really been thinking about it.
Thank you. Do you want to say something? Okay. Yeah, I'm going to sort of say a couple things. First, you have to walk before you can run. So I think this is, a really great first step. Just to put this realistically, the internal CMS calculations are that a single quality measure costs between $500,000 and $1 million to develop in somewhere between 3 and 5 years. So this is a long, expensive process. Part of this, we want to make sure we get it right. So the TEPS, that Dr. Fasipe mentioned, the validity and reliability testing, going through the CMS, that what we call the consensus-based entity process, putting into a rule, all those things take a long time. So that's why the process moves slowly, but hopefully we do things well. Perhaps I'm just a little bit scarred by meeting with interested parties all the time, but whenever you start talking about broader measures like missed days of school and all those other things, then you're going to have a lot of people lining, if you're CMS, you're going to have a lot of people lining up at your door saying, it's not fair to me because I take care of sicker patients, because, my hospital's in a different community than someone else's. So that's why it's really important, when we try to work on these measures, it's sort of like what's achievable by everyone, and what, how do you risk adjust, or do you even need to risk adjust? So again, a little bit of, that's the world I live in. It's whenever we do something, it's, well, you're not fair to me. And so that's just what comes into play as we try to, look at broader things that, should make sense, but then how do you make sure it works for everyone? We'll take one more question and then we'll go to break. Sir, you had a question?
Actually, it was pretty much addressed. This, how do we get to the point where there's some teeth to these measures not being implemented? Because that's always the issue. I know there's on the private side, there's JCO, but to the extent, I think you addressed how CMS can tie that to payment, and then that can be a consequence if you're not meeting the measures.
Well, both that and public reporting. Again, like I said at the beginning, when I spoke initially, you'd think that it was all about money, but it's a lot about stars and, your star system and personal, hospital reputation. And they're as adamant about their stars as they are about their money, which is good. It means we have two levers to address things. Let's take one more question from the audience and then we'll go to break.
As part of this, and Dr. Liam brought it up, this patient-specific treatment plans. And this goes back to, in my mind, right, one quality measure is, and what we're trying to get out to the community is that everybody should be seen by a sickle cell expert, right? And you need that sickle cell expert to develop your patient-specific treatment plan. Yes, others can do it, but really to ensure that you're getting high-quality care, it is making sure everyone is seen at least once a year by a sickle cell expert, where part of that plan is to develop the patient-specific treatment plan so that when you show up in the emergency room, it's not some poor emergency room physician going, I don't know, I guess I'll give you this, but that there is a plan. So taking 2 steps back before a patient even walks into the ED, although again, ED care is really vitally important, but right, establishing what could be an easy metric to identify that everyone has a sickle cell expert who's managing their plan.
And the reason that's not easy is, how do you define a sickle cell expert?
Well, I'm glad you asked that. So as
I'm sure your organization has its own preferred way of doing that. Yeah.
So sickle cell centers, we recognize over 100 centers in this country covering, 37 states now, 39 soon, where we have identified people who meet certain metrics who are identifiable sickle cell experts.
And again, the government issue, and again, I've been here for 10 years in the government, it's really important not to pick winners and losers, because when we pick winners and losers, we get in trouble. So how you create an objective measurement of experts, that's not organization centric. That's not, somebody who may not have the training, but has been taking care of sickle cell patients for 50 years. Maybe so that's the issue. And again, I don't mean to be so cynical or downbeat, but it's just the nature of what we do in government is whenever we pick a winner or loser and say, yes, you are the expert, somebody's going to tell us, well, how come I'm not the expert? So let me stop.
But I think the government does have a long history of identifying experts in terms of clinics and fields. So you used to have sickle cell centers through the NIH. That went away for a number of reasons. You have hemophilia treatment centers, which have values through the federal government. So I think there are definitely ways in which, even if you're not identifying Dr. Lansgren, who has been practicing for
and who's attributed, yeah.
But the government does have ways to identify and certify centers of excellence in different fields, and I think there is precedence for that could be applied to sickle cell disease.
So again, not meaning to be negative, but when I was giving my talk, it's, what are the challenges we need to overcome? So who, if that patient with sickle cell disease does not have a treatment plan, who is that fault? Who is that negative finding attributed to?
Well, I think the standard would first have to, I think one of the challenges that sickle cell patients have now is that even if they have a plan, the ER doc doesn't look at it or refuses to look at it. But that's again having to have a measure in place in terms of tied to quality. So if, for example, the measure is that you are supposed to ask if a sickle cell patient has a plan, and did you do that, yes or no? And if you did not do that, then that's a consequence. And so I think you can establish certain standards of care for sickle cell in an emergency room. And I think that's what's lacking, because if you don't have that standard, if somebody refuses to, a patient comes in and says, Dr. Lansgren has me a plan, and they say, I don't know who Dr. Lansgren is, I'm going to do it this way. If that happens, there should be a consequence. And so first you have to establish what that standard is.
Okay.
And I think the federal government does have the mechanism to do that.
Fair enough. So that plan has to either be available because of interoperability, or that patient has to carry that plan with them as a hard copy. So if I see a patient in the ER and they have a plan from Dr. Lansgren, but they don't have it with them, and I can't access it because through interoperability, then it doesn't help me. So again, that's just, I don't want to go too deep into that, but again, it's just, that is sort of one of the reasons I wanted us to talk, one of the impetus for this town hall was to sort of say, here are these wonderful ideas, and here are the challenges we have in actually implementing these wonderful ideas. And the same, what you're describing for sickle cell plans is also true for people with advanced directives, right? People with DNRs, and it's like, well, the doctor in the ER can't access it.
Right, and
so-
that's a good example, because if, for example, you do have an advanced directive and you're not able to access it, or for some reason, then that hospital is not going to be held liable for that. If,
Yes.
however, they could be, there is a standard. If you had that DNR in place and all the steps were followed,
Yeah.
and that hospital or hospital employee didn't follow it, there's a consequence to that. And so there'll always be exceptions, but coming up with that standard and saying, this is what is expected, there'll always be exceptions. The patient didn't have it, or there was a data breach or something, there was a hack and you don't have your systems up, and of course that can always happen. But if you have the standard, and I think my point is that the federal government right now, I think, has the ability to set standards for certain disease states, and they can do that. And if they do that, and sickle cell can say, okay, this is it. I mean, and I have some experience in hemophilia, even in terms of dosing, if you look at the CMS regs for dosing, clotting factor was one of the first drugs that was paid under Part B. And you look at that, the CMS regs basically says, and I'm paraphrasing, is ask the hemophilia treatment center, right? So if the hemophilia treatment center that they have a standard for is recommending that dose, and CMS says, I'm good with that, right? And so that's the type of standards that you have to have. And that's why folks like the National Alliance of Sickle Cell Centers, when those standards come about, it's understanding how can we get CMS to adopt those standards so it becomes a standard, and the hospitals will want their stars, they will want their payments, and you have that standard.
Okay, thank you very much. Let's take a 10-minute break and come back at 2:10. Bathroom across the hallway to the far and then turn left. So I think we ended with a question from the audience. So are there any questions from the chat?
Hello. So we have another question from our chat from Dr. Aurora. He wrote, "These are amazing updates and presentations. Sincerely appreciate the dedication to SCD patients and families. I'm curious if any of the gaps identified, TCDs, getting PCN to children, transitioning children effectively to adult care, etc., are utilizing implementation science techniques. I understand the NIH has a branch of implementation science headed by Dr. Kara Lewis and also has a D&I branch. Curious to see if we are able to partner with those branches to enhance uptake of evidence-based care.
You guys want to speak to that?
I can.
Yeah, I think that there are many, 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 many opportunities for implementation science, and I believe that the NIH has funded implementation science centers within several institutions who do implementation work specifically in sickle cell disease. I think, from the ASH standpoint, I go back to, the efforts that we've put into in developing the clinical practice guidelines and the need to implement them and to disseminate them around the various approaches that they're using from an educational standpoint as well. I think we're really, we have a fairly good grasp, I think, in understanding how many people are accessing the guidelines, for instance, through the portals and the websites on ASH. I think what's a little bit harder to tell is whether or not the guidelines are implemented in a way at the provider level or the institutional or programmatic level, and what outcomes we have related to that. But that's something that is really, really important to the work that we do at ASH. The questions about specifically about TCD screening and about penicillin prophylaxis transition, those weren't the topics of specific recommendations in the current guidelines. However, those are important, and I'll let Dr. Fasipe speak a little bit more about those areas. I think from an implementation standpoint for transition, what I could speak to is the learning community that ASH has launched specifically recently around having institutions share with each other their ideas and standard practices around transition programs, development of those programs, and development of lifespan practices or lifespan programs. There's a lot of, not disagreement, but I would say lack of consensus around what constitutes a model sort of transition program, but it depends a lot on a lot of different factors, including whether or not you're a pediatric institution that also has an adult institution tied to your pediatric institution, whether or not your sickle cell program has both a pediatric and an adult component. So there are many, many different models of transition out there, and there's a lot published on that.
Yeah, and I just wanted to add about, in addition to the NIH funding for implementation science, those that are familiar with PCORI, Patient-Centered Outcomes Research Institute. I wanted to make sure I get the acronym right. And they have several grants trying to assess comparing effectiveness of standard of care to something novel, but the target is not a drug, does this drug work better than another, but a process of care, like how do you improve that patient outcome experience? And then I want to give a shout out to HRSA a little bit. Although their model is to look at access to care, and you heard earlier today about the regional grants that are trying to improve access to care for sickle cell disease. The ones that they prioritized were hydroxyurea, as well as vaccinations, and transition is in there as well. I will say that having seen parts of the side of the HRSA approach, part of the side of the ASH approach, it's interesting how you can look at the different layers of this and where you can implement change in one part of the system, and how far that goes versus other parts. One of the things with the ASH learning community is that shared experience. So you have different centers discussing their quality improvement initiatives. And I will say that both of these examples, ASH and HRSA, at the end of the day, it's still a piece, these are reflective of certain institutions. And so how do you think of something that impacts people more broadly? Not only do you share the data nationally at meetings like this and others, but also think of a way to help to coach those that want to start something for themselves. So another phrasing of what I want to say is there's this high goal of well, these are the implementation science gurus, these are the quality improvement gurus, or people that have access to more patients. But then there's the level of what does it look like around the country? How do you make sure that these same studies, the results of them end up trickling down to the level of the patient wherever they are? And so it'll take a lot, but I am happy about those implementation centers and the work that I've been seeing coming out of the PCORI driven grants as well.
I'm going to be a cranky federal official and say that it's amazing that when you pay people differently for implementing or not implementing something, that suddenly they implement things. That's one of the beauties of being at CMS. I mentioned previously, I work in a pediatric ER. And I mentioned also that I work a lot on the sepsis measures for CMS. And, I was working in the ER and one of the ER techs had a, on the ID badges, they have little different laminated tags. And one of them were the criteria for SEP 1. It's a process measure for all the things you need to do. So when faced with the hospital either losing money and or doing worse on its star ratings, the implementation science of the hospital administration was to give everybody an ER a little laminated tag that said, here's what you have to do. So again, I think, I believe in academics, but sometimes just paying people differently gets them to do things. And that's, again, the beauty of CMS. We had last question was in the chat. So we had another question in the audience.
Building on the comment that you just made, could you talk a little bit about what some of the current or future potential incentives may be for hematologists caring for patients with sickle cell disease from a monetary perspective? As we all know, the altruistic need and desire to do the right thing, I would say, is largely always there. But there's only so many seconds in a day to be able to accomplish it. And as you noted, providing incentives can help redirect some of the priorities for administrators and others to give the resources needed to these sickle cell disease clinics. Could you talk a little bit about what CMS might be doing in the future to support
Yeah, I'm going
that?
to try to say that without getting myself into trouble. Certainly, for quality measures, there are quality measures that are pay for performance that we have: the Hospital Value-Based Purchasing Program, HVPP, the MIPS program, Merit-Based Incentive Program, for physicians that have money tied to them. So we can do that. A lot of the other programs don't, and just to be clear cut, the ability of the different programs to be either pay for performance or pay for reporting, and what the financial incentive or penalty is statutorily defined. So we don't do that, Congress does. Going a little bit on a limb here, I know that I think last year, there was an effort in Center for Medicare to pay physicians more money for taking care of primary care patients. And there were complex care codes, longitudinal care, and I'm going to mess up my terminology there, but there was an effort to say, here are complex, how do we incentivize primary care physicians, who aren't really paid as well as specialists to do this. And so that was there. Whether that ever happens in hematology, I would say it's above my pay grade, but certainly there are mechanisms where you can pay people differently. There are what we call MVPs, the value programs, which are specialty based. So you can imagine a scenario where somebody has a hematology or a sickle cell MVP, and we pay them more if they do that MVP. So there are ways to do it. I think we're all excited that we have a great measure. I shouldn't say that since it's not officially accepted by CMS, but I'll let you guess. We have a great measure that's going to be up for consideration, to make what we call the MUC list, the measures under consideration list, which we published December 1st. But that's, we're still at that very first step, although I do recognize that the different, the disparities in care. I answered as much as I could without getting fired.
Yeah,
Right.
Yeah, we both got excited about that. It's difficult. So Mariah and I are both adults with sickle cell disease. I deliberately chose pediatrics because when I was thinking about what it looked like to take care of adults with sickle cell disease and what it looked like to change the landscape, I felt I could do that more effectively in the pediatric space. When I got well, as I continue to age and as I continue to hear stories of the adult experience with sickle cell disease, and also living in a state where I would say my lens or for CMS is really a pediatric one. There's not every state is a Medicaid expansion state. So you end up seeing that when I'm hearing about, well, this is what Medicaid's going to do, this is what Medicare is going to do. And then part of you is kind of like crushed that, okay, well, only certain pieces of the population might benefit from this change. So it's something I've been wrestling with when Dr. Stockman was discussing federalism and this balance between what does the federal government do and what does that state independence allow for healthcare delivery. I hope that this work can impact beyond, an ideal situation for whatever that means. And for sickle cell, that would mean maybe an adult can also receive benefits, but would it inspire changes on levels even where you don't see states that necessarily have opted to include adults with chronic illnesses in their Medicaid and Medicare programs? And that was very long-winded, but yeah, it's a reflection point that it's one that I continue to wrestle with as we do this type of work.
I also just wanted to go back to this idea of financial incentives and what CMS, has in mind. I wonder if part of it is that we need to shift away from not only thinking about and having institutions and hospitals think about the improvements and reimbursements, but really about the cost savings as well. And I might be a little bit naive and idealistic about thinking about this, but I do think that we have an opportunity here through all of our collaborations to really help hospital systems and institutions support them in modeling what those cost savings might be, because I think if you show them sort of what that results in, then hospitals and systems are better able to say, hey, we are much more in a position and more likely to invest resources up front. I'm always all about trying to convince people to invest the resources up front, to partner with IT and with others to implement ways so that we can either implement sort of quality improvement approaches related to the quality metrics, working to enhance our EMR. I was thinking earlier, and I had a conversation at lunch with a number of ASH folks about the fact that even with the challenges that we have with implementing and disseminating our guidelines, wouldn't it be great if we can continue to really leverage the EMR in building appropriate dashboards? And I know that that's part of what ASH is trying to do, Research Collaborative and the Data Hub as well, but providing institutions and teams with the ability to monitor their own progress around quality metrics, like how well are we doing with delivering pain medications. At our institutions, for instance, we have a clinical care guidelines that's related to specifically to pain medication delivery, and we can pull up the control charts to see how our emergency department is doing. And we're trying to build in more enhancements of the EMR and to the order sets, and to build in education and other strategies to improve adherence to guidelines as well. So I guess I just want to emphasize, the thinking about cost savings rather than just improved reimbursements for patients as an incentive.
Yeah, this is, I want to underline this point further. Earlier, we had a question and a comment from Dr. Lanskron about this concept of maybe a clinic or a center saying, oh, we don't see sickle cell disease. Most of that language stems from this issue about reimbursement incentives and the perceived cost of caring for sickle cell, in addition to all the other stuff, the stigma, the difficult, all these other challenges. But underlying a lot of that is the difficulty to, you can see how to care for patients in the hem-onc world very clearly for certain conditions, and sickle cell doesn't have a clear way. And so outside of passionate individuals, those that are fascinated by the disease, and institutions that have figured out what it looks like to think about another way of thinking, cost savings way, this is something that is quite critical because it does impact that ability to get quality care, and not just the lack of so-called experts for sickle cell disease, but also the fact that the institutions are not able to perceive the cost benefit ratio for caring for sickle cell disease. But you cannot, to your question, like how can you turn away a disease population? You would think that that should be something that we should not do. And I appreciate CMS thinking about ways to make it more feasible to care for sickle cell disease in this kind of multi-dimensional way, like all the components of that.
So I think when I first started talking with Dr. Landstrom about 6-7 years ago, I was the clinical lead for the oncology care model. And the oncology care model, the premise is that there's more efficient care that can be provided. You can prevent hospitalizations, you can prevent complications of chemotherapy. And that if we take some of those savings and share them with the clinicians, everybody, gets incentivized to do better. And we actually first started talking about, could we do that for sickle cell disease? Could we basically create a benchmark price for sickle cell disease care? And if you did better, if your patients didn't have strokes because you did transcranial Dopplers, and they didn't get admitted because they were in hydroxyurea, they didn't have sepsis because they had pneumococcal and meningococcal vaccinations. And then if you did such a great job and you saved money compared to a benchmark rate, we could do something with that. And I was all gung-ho when I was doing that. And then we ran headlong into the concept of Medicaid. I love you, dear. Just not picking on Medicaid, but the concept that we couldn't do anything in Medicare because more than half of Medicaid patients more than half of sickle cell patients have Medicaid, and so there is that opportunity to share savings, and those actually exist. So if you think about ACOs, accountable care organizations, and Medicare shared savings programs, MSSPs, that's basically what the government doing is gradually shifting the world from fee for service, the more widgets you provide, the more we pay you, to we're going to give you a certain amount of money to take care of a patient with a certain disease. And if you do a better job with that, then you can get part of those savings. That when you hear about ACOs and MSSPs, that's what those are. So now here is the flip side of that, right? We talked about earlier is how do you risk adjust for that? And you may be familiar with Medicare Advantage organizations. There was some, I think, Washington Post article a few years ago. It was a Wall Street Journal, not even a few years ago, I think a couple months ago, where, coding intensity, where organizations were identifying basically every condition that a person had, even if it wasn't significant, because Medicare paid you more, Medicare Advantage program. So how do you, when you start doing these things, how do you again risk adjust? And again, certainly not, don't want to be Debbie Downer, but when I first gave my talk, it was sort of like, here are the challenges we face, how do we overcome them? And so I think it's incumbent for me to basically say, yeah, this is a great idea, but here's where you got to figure this out. And the only thing I'll tell you about, I worked in Senator Wyden's office for a few months, 6 months when I was here during my fellowship. And every disease has an advocacy group. So the first moment we start to say, we're going to give more money to sickle cell disease providers, I will have 53 different organizations lined up outside my office saying, well, how come not us? So that is, again, the challenges of what we're trying to do is that we're all interested in sickle cell disease. We all think it's important. And there are people with neurodegenerative diseases and all kinds of different things out there that also think their causes are important. And so given a limited pie, how do you deal with all of that? Other people from the audience, sir?
I mean, CMS, the M in CMS is two things, right? It's Medicaid and Medicare.
Medicare, Medicaid.
So can you explain a little bit when you say you ran up against Medicaid? CMS still has some leverage on the states in terms of the work that they do. So can you expand on that a little bit?
Well, I'm gonna let Deirdre speak to that. I mean, I think the issue is they're state-based programs. So Medicare, we could say we're going to have this model and everybody in the country can participate. And in Medicaid, it's more state-based, but I'm way out of my depth.
Premise before, when you respond, because on the CMS, on the Medicaid, every state has to provide a state plan, a state plan that has to be approved by CMS. So I think it's not just a state-based program.
I'm glad to hear.
Sure. Yeah. And I'll be happy to speak to that. So you're absolutely right. Every state runs their own program within broad federal guidelines. So their state plan, which they update frequently in the form of what we call state plan amendments or SPAs. Sounds really great, right? Very rarely, because our goal is certainly to work with states to get to yes, right, to get to approvable on a state plan amendment. And so, we work with states to get to their sort of coverage goals, as long as they fit within the broad rules of the Medicaid program. So I talked a little bit about federalism, right? We go back and forth on how we feel about it. There are pros and cons, and one of the strengths of it, of the approach, of the way that the Medicaid program works, is that we have 50, 51, 53, 56, depending on who's counting as states. And believe me, the statute is really complicated on who counts as states, but I won't get into that now. But we have a number of different laboratories of how to, of implementing Medicaid and demonstrating kind of what works in different places. And so one thing I've been thinking about in the course of this conversation is how important it will be in the development of measures, but then in the implementation, right, to partner with states, ideally to partner with some state Medicaid agencies who are interested in seeing improvement in care for people with sickle cell disease, to show exactly what your point, Dr. Liam, what's the return on investment, sort of what, because that is something that speaks to states and inspires them to go and change coverage or update plans or do quality improvement, is to see, to have other states demonstrate what works to improve care. And so I think that's a role that the RM, the Medicaid M and CMS can play, is helping to facilitate that learning across states around what is working. So I'm thinking about, as you're, kind of developing measures and then working to implement them to try to see if they're really leading to improvements in quality of care, that hopefully engaging with states to as partners in that implementation science kind of phase will be a really key step to then spreading and scaling the use of measures to drive improvement.
Can I just follow up? Does it help the states if CMS, the Medicare part of CMS, does have a measurement and a standard that they could then follow? Because even though that would be helpful to the states, correct?
Right. Yeah, absolutely. And as I was talking about before, we have the Medicaid and CHIP core sets of measures, which are at the state level, but then states in their own quality of programs, depending on how they're focused and what conditions and what issues they're focused on within their state, draw from lots of different measurement programs, including other CMS programs that are managed by CCSQ, and even, HEDIS measures, other measure sets that are out in the world that you are all a part of. So I think all of our pieces of the puzzle ideally can work together so that in the state Medicaid context, there's different places to kind of draw from and build a quality improvement program for people with sickle cell disease in the states that are focused on that and should be.
And the only thing I'll add there is, I think that was, when I showed that map where I think it's what, 70% of patients with sickle cell disease are in 6 states or 7 states, something like that. It's both an opportunity and a challenge, right? So the challenge is we can't put it into the Medicaid core set because it's not in 25 states. The opportunity is that we don't have to deal with 50 states. If we deal with 5 or 6 or 7, we've got most of the sickle cell disease world covered. And in fact, Dr. Wong, Captain Dr. Wong, when we first started talking, a few years ago, there was a small grant in ASH, Assistant Secretary of Health, not American Society of Hematology, to work on sickle cell disease improvement. I think we'll end up covering 1 state, and I think it was New York State, if I remember right, David. Yes, we did that. So again, both opportunity and a challenge. We don't have to focus on 50 states. We can focus on 7. Other responses? Okay, then we'll go to the chat after that.
My name is Rudy Williams. I'm a sickle cell advocate, former caregiver for over 50 years to a few warriors in our family. I represent the rural community of Maryland. And I'm just curious, all quality measurement information, which is really great stuff. Is there any priority given to those rural communities who really and truly don't have access to the care they need?
So there's a different payment system for critical access hospitals. They're paid on a cost plus, I think, 1% basis. The rural hospitals, rural emergency hospitals have their own payment system. And as you may remember during the talk, the ASH time to treatment measure is going to be, proposed to be part of the rural emergency hospital quality measures. But I mean, to answer your question directly, there are resources to those rural hospitals, and they are, I said, within, we call CAHs, critical access hospitals. They are funded differently than other hospitals in the United States.
And
I presume it's public cause or cause for public information. It's not an area I work in, but if you were to talk to your hospital administrator, ask him or her if your hospital is a critical access hospital and what the criteria are for that. They're paid on cost plus basis, which is differently than any other hospital in the country, to acknowledge their needs. Okay, you guys want?
Yeah, just to add, one of the parts, I don't know if we fully emphasized it in either of our talks, was this concept of what does it mean to have access to high quality sickle cell care? What does it mean to be in close proximity to somebody that you view as an expert? And one of the models that has now kind of been our, you'll have taken flight, if you will, is this concept of a hub and spoke model, where if you define a hub as maybe an area that has more resources, but the various spokes can be satellite sites and communities where the resources may not be as vast, but there's communication streams and mentoring, if you will, between the sites where you can get better care to areas that have less resources or more distance. And leveraging technology is part of this. So whether that's leveraging the ability to have Zoom conversations with a provider that maybe has seen more sickle cell disease and can answer more questions versus the options for telemedicine. So maybe I can't make it to my doctor every 3 months physically, but maybe once a year I go physically, and the other times I can do a telemedicine visit. So the rural community, it's quite an important one. Like for my state, it's one I lose sleep about, the kids that have to drive 4 hours, 3 hours to get to good care. And so I was really excited that the CMS, when they consider measures, part of that pocket is what is that rural experience? And in this particular case, rural emergency departments, but it's an important question to ask for all components of sickle cell care.
And those programs exist. So you may or not have heard of Project Echo. You've heard of Project Echo. So Project Echo was a hepatologist, I think, University of New Mexico, who felt that people in rural areas weren't getting appropriate care, or state-of-the-art care for their hepatitis C, I believe it was. And he created a program where he was reaching out through telehealth to a lot of rural areas throughout New Mexico. And I think CMS has run with that. I spent a couple of weeks working in a pediatric oncology clinic in Rwanda that was, I don't know, sponsored by his partners in health, but they had close links with Mass General or Brigham. And so once a week we had a teleconference with Brigham and said, here are our difficult patients. Now that's a whole different world, right? Because the support services that you can provide in Rwanda are very different than the support services you provide in Boston. But nevertheless, the technology enabled, people to get state-of-the-art advice, if you will, for that. So yes, I think the only good thing, the silver lining of COVID, God, what a terrible thing to say, was that we all learned how to use telehealth better.
So I've been doing a telementoring echo since 2015. So before good old COVID, where we have now 50 people across the country who participate. We provide CME and MOC, which we pay for with the help of HRSA, because it's part of our HRSA grant.
Okay.
That pays for those resources. So it's not free. And the concept of a hub and spoke is great and very much what we support, especially as part of the National Alliance. And we just opened a spoke oh, now what is it, Rudy? 2 years ago, here with the help of our community to help start a spoke, right, hop, skip, and a jump away at the hospital right outside of DC. It's a lot of work. And
Mhm.
as the hub, we have had a grant, so there was some compensation, but when the grant goes away, there's no compensation for being that hub, and how we maintain that over time is something we have to think about and provide that support locally. The clinic's doing great, although it is now a very busy place, but the hub work is significant, time consuming, and without a grant would be impossible.
Yeah, and how you deal with payment. I know that's sort of part of the whole telehealth issue, the broader issue of telehealth. And I don't know how CMS has addressed it. That's not part of the world I live in, is in telehealth, who gets paid for what part? I mean, is it the satellite clinic or is it the hub? So it's exactly that issue.
Yeah, well, you just said you don't, the
Yeah, it's not-
telehealth is not your area, but I
Yeah.
think it's a critical area
Mhm.
for quality as well, especially in sickle cell disease. I think one of the things that folks are running up against now is the changing in the rules post-COVID in terms
Mhm.
of reimbursement. And so that's something that I think ties to quality, because you talk about access to care, whether that's in rural or even in cities. Telehealth, when somebody, I mean, we support the program that is, we have spent about $16,000 in transportation assistance in the first 6 months of 2024. And so people have a hard time getting to clinic.
Mhm.
And so CMS needs to look at their telehealth reimbursement, not just for sickle cell, because it's not unique to sickle cell, but that needs to really be revisited in terms of, and I know CMS, a major concern for the federal government is fraud and abuse, and telehealth is a risk. But I think we have data to show that that was not an issue during the time, and it really improved care.
Yeah,
So.
and the larger issue there is with, let me just say, it has to do with with bundled payment systems, if you will. So how do you pay for things? So in the oncology care model, and I spent 5 years there, so if I keep referring to it, it's because I spent a lot of time there. The question was, if you have a target price and you depending whether you're one-sided risk or two-sided risk, whether you gain money or lose money, or is, we have the conversation, if it's 3 o'clock on a Friday afternoon, does it make sense to pay for the $50 cab ride to get your patient to your office before it closes so you can see them? Or are you going to, take the ambulance ride, the cost to your bundle of the ambulance ride and the ER visit and the possible admission? And so that's sort of, when you start thinking about things globally as opposed to piecemeal, that's one of the things that comes up. Now, again, because nothing in government is simple. Is that considered an inducement? Does it violate the law? So you have to deal with those issues. But yeah, I think it's sort of part of when you deal with a bundled payment where you need to provide care for this patient for 6 months. Don't give me your piecemeal stuff. 6 months. Then you figure out these sort of inducements and things. Then you can start taking care of patients differently.
Just a couple of things from the Medicaid perspective. First of all, on telehealth, we do have a telehealth toolkit on Medicaid.gov. There are lots of flexibilities. Dare I say more flexibilities in the Medicaid program than Medicare for coverage of telehealth. So again, up to state option, but there are a lot of options for states to cover and address some of these challenges that of course exist, right, with who gets paid and whether it's sufficient. But I do want to make sure folks know about that telehealth toolkit. And also briefly on transportation, non-emergency medical transportation is a required benefit in the Medicaid program. So states do have to cover it. I know you're asking us to mandate coverage. We can't mandate coverage of that many things in the Medicaid program, but if they're in statute, we can. And that is one of them. And I believe we have some tools on Medicaid.gov around non-emergency medical transportation as well. I know, again, challenging to get it to all the people who need it. There are some certainly innovative models out there. I think testing different ways of more efficiently delivering non-emergency medical transportation. So I'm not naive about the challenges there, but did want to mention that is a required benefit.
I just want to mention, right, that benefit is great if you can schedule your crisis, right? Because a lot of the transportation that's offered is to and from an infusion clinic for cares, which then avoids the ambulance and the emergency room visit, but but you
Right.
can't use CMS. for
The
that.
scheduling is absolutely understood. I get excited when I hear some of the models of people partnering testing with different ride share and sort of on-demand ride services. I think there's sort of mixed evidence on that, but lots more opportunity to test out, making sure that people can get the transportation exactly when they need it.
Want to say something, and then we'll go on to the next question.
I wanted to emphasize the need for more data. So, and give a shout out to CDC. So that map that was shown earlier by Dr. Klein that showed like these states have this much sickle cell, these states don't have. When you look at each state, it's not that paintbrush, right? Some are concentrated in various parts of the state. And I will say most states don't know where all their individuals with sickle cell reside. And so with initiatives like the CDC Sickle Cell Disease Data Collection Program, where states can actually now have their own visual of where sickle cell resides, and the answer sometimes causes surprises. Our initial dip in the toe, we realized that yes, they're populated in our big cities, but there's also several rural areas that have sickle cell disease, and that makes you pay attention and hopefully drive more resources to that area. And there's so many other layers to that conversation, but data is also an important tool in seeing all of these goals met.
We'll go to chat.
I think that's a really great segue back into, we have some folks wanting to weigh in on the priorities for measurement that were discussed or
Sure.
raised in the
That'd be great.
previous questions. Perfect. So I'm going to go ahead and folks online who wanted to comment. Maybe some members of the HSAC team.
This is Kyle Campbell from Health Service Advisory Group. Yeah, we were really interested to hear from the participants based on the slides that Dr. Fasipe presented, which of those low-hanging fruit and existing measures would be most interesting to the group to pursue for future measure development.
And I will say, as a reminder, so there were process options, there were some outcome options. It was probably a cluster of slides.
Can you go back on slides?
So yeah, maybe.
Maybe I can do it.
Yeah.
Well,
Oh, and I
do that.
can.
Help me. Can you help me? Tell me which is your slide.
Yes, if we go back a little here, let me, we're gonna rewind back to,
There.
so this would probably be a good summary for the areas. And so as a reminder of process measures with strong guideline support, hydroxyurea in the adult population or vaccinations. And then for things like neurocognitive testing. Also, this question is posing, should we target health plan level? Should we target another facility like the one that the pain measure does? Should we look at the state level? So there's a lot, but which ones do we think make the most sense to think about? You emphasized this, and I kind of hinted at it too. It does take a long time to develop a measure. And so the goal would be, we want everything to have a measure. But if we are trying to use our limited resources the most creatively and responsibly, in addition to how we looked at pain in the emergency department, what other areas should we start to think about as well?
And I liked hydroxyurea for adults. I started down that path as well. I guess the NIH guidelines, NHLBI guidelines, you guys can speak to that more than I can, is that in pediatrics, it's recommended for every patient. And in adults, it's supposed to be shared decision-making, which people got caught up into, well, what's like the 100% number? If it's shared decision-making, how do you judge that? The other point was that about 10,000 Medicare beneficiaries have sickle cell disease, so 10% of the total number. And how do you attribute that? So again, one of the things I didn't mention in my initial presentation was attribution, right? Whenever you have a measure, it's who's on the hook for that measure. And is the person, and if you create a measure and the person who is on the hook is not, or the clinician is on the hook is not, or entity is on the hook is not in control of that measure, you're going to get a lot of negative conversation. So when you think about measures, also think about attribution. Who's the person, I keep saying person, but really facility person, whatever, to whom that quality measure is attributed, that outcome is attributed, and does that entity have control over the outcome?
Can you hear me now? Yes. Jennifer Bright from the International Consortium for Health Outcomes Measurement. So 2 comments. One, don't invent something until you look around and see what already exists that can be adapted. I think you mentioned that earlier, like we should look in other disease areas, other domains, for example, pain measurement, pain outcomes measures. But for example, somebody brought up the notion of preventing stroke. That's an outcome measure. That's an outcome measure that should be part of sickle cell disease. If that's what good looks like for a sickle cell disease patient is avoidance of stroke, then that should be an outcome measure that we use. But I would say that one thing, having observed this on an international scale, one of the pathologies we have in the United States is that we want to build something new. It's got to be unique to our experience, our culture, our payment system, whatever. There are existing clinical outcome and patient-reported outcome measures in use all over the globe that we should look at and see how they can be adapted to this specific disease area, because this is a unique condition, I agree. But one of the things I also heard is that because it's a rare disease and it's a smaller population, that it's less easy to adopt measures or to think about measures. Well, then look at cross-cutting measures, look at cardiometabolic measures, look at pain measures, look at stroke prevention measures, and figure out how to adapt them to the needs of where sickle cell disease outcomes perspective is right now, and make it a dynamic conversation. Try, use what's available, try it, look at case mix variables, yes, and test, see what we're learning first. What are we learning about achieving outcomes that are important to patients living with sickle cell disease, and then adapt as necessary. But don't start from the premise of we've got to build something brand new right out of the gate. That is a broad cautionary plea. Thank you.
And I agree. And I'm really an optimistic person. I'm a pediatric oncologist who always wears rose-colored glasses. So I apologize for sounding like this, but I really do want to share with you, my pain in trying to develop some of these measures, right? So the measure you talked about is making sure kids, less than 16 get annual transcranial Dopplers. Who do you attribute that measure to? Is it the physician who sees the patient and maybe hasn't seen the patient in 2 years? Is it the health plan? And maybe they're a part of a Medicaid managed care organization, and 6 months into that annual period, they transition to a different MCO. So again, not to say these challenges are insurmountable, but for those of us who deal with quality measurement, this is what we struggle with, and this is what we have problem is it's fine to say we need to measure this and do better at this, but then you need to answer the question, who do you attribute it to, and so that I just say just for that reason, again, there are ways to overcome this, but I just want everybody to appreciate the complexity of quality measurement when we do this is how do we attribute things to the right person, right entity, plan level, hospital level, clinician level.
There are a number of us in this room who have registries, right? And I think part of what we need to do is stop thinking about the barriers there are to Medicaid data, but try to work together to figure out how we leverage what registries already exist to help answer a lot of these questions and meet the outcomes. I'm just hearing a lot of this isn't going to work and that isn't going to work,
No,
but we've been doing this for, these
Yeah.
barriers for a long time. And right, the fact that we're talking about hydroxyurea, right, hydroxyurea is really important, but it really has to be about who's on disease modifying therapy,
Mhm.
right? We've moved beyond guidelines that were written over a decade ago to sort of broadening our view, and just want to make sure we don't lose sight of all the work that's being done to try to improve quality.
And again, registries can be used for QCDRs and MIPS. And again, I really do apologize for being negative. The intent is not to be negative. The intent is to share with you the challenges the question would be, well, CMS, how come you haven't done these 10 things? These have been around for, how come you haven't done them? And this is, I'm trying to share with you the challenges.
I think from my perspective, I think one of the things that, and doctors mentioned in terms of using examples, what I want CMS to know today is that you have the resources and the allies to answer those questions.
Great.
Right?
And then we
So
look forward, we look forward to
right.
your organization submitting a quality
because
measure.
we know how, if you say, who should this be attributed to? I think we can make those recommendations. Folks like Dr. Lanscron and others can make those recommendations. We have a project going on right now through the state of Maryland to look at transcranial and Doppler at Johns Hopkins. So we have shown ways in which we know how to say, okay, this is what's needed. This is what increased participation from 50% to over 90%. And when this was missing, it dropped back down to 50%. And so we can answer those questions. And I think what, in terms of the positive aspect that I'm taking from it is that we can do this. If we can answer, because I'm confident that we can answer those questions. So for every question that you might have and you have to pose and the feds have to pose, we can answer
Great.
those.
We'll look forward to chatting with you.
We have the ability to do that.
Okay, fantastic.
Can I just add, a part of what I'm hearing from this discussion is not the attribution part of it per se, but also the accountability, right? It's referring to accountability. And I think in some ways, the ED measure, quality measure of pain medication delivered under 60 minutes is one that, is kind of confined to the emergency department setting and all of the stakeholders in that setting. I think that questions about, TCD screening and hydroxyurea prescriptions, penicillin prescriptions, those can all be attributed to the sickle cell clinical team. I think who's held accountable probably is the hospital system. And I would hope that if there was an implication for financial reimbursement or, a negative impact on cost savings that are tied to those quality metrics, then the hospital will find a way to work with the individual teams to improve their ability to adhere and to make progress towards those quality metrics. I think I guess maybe I'm having a harder time understanding the term attribution versus accountability. I think we're all held accountable for really providing the best care for our patients with sickle cell disease. And if that accountability has to come top down from the institution or the systems you're working in, then I think most of us who are sickle cell providers here would accept that challenge.
So in Chicago, there are 4 or 5 different children's hospitals, pediatric programs, a city of 5 million, 6 million. So how are we going to divide up those sickle cell patients by hospital system? Who's accountable for which population? How do we do that?
No, it's almost a little bit easier. It's part of the reason why I think, to Dr. Fasipe's point earlier, that I chose to work in the pediatric world rather than in Dr. Lanscron's world. But yeah, I mean, there's been a lot of talk within our field for, when patients are seen by a comprehensive program, how do they stay in that program and what are the quality metrics around that? But I do think that there's probably some shared responsibility, probably from a Medicare standpoint. It makes it a little bit more complicated, but your patients should, at least from a pediatric standpoint, the vast majority of them do identify with a single program, much more challenging in the adult world. And so, but when we talk about TCD screening, we could start off with the pediatric programs. Certainly for penicillin prophylaxis, it's much important for the pediatric program as well. Many of those preventive strategies start at the pediatric.
And we have a federal program in hemophilia. You talk about using models, right? They're hemophilia treatment centers. So when you look and you say, okay, in Chicago, and you have maybe 3 I can think off the top of my head in terms of hemophilia program, sickle cell program, I mean, hemophilia pediatric programs. We don't ask that question. How are you going to divide the sickle cell, I mean, the hemophilia patients between those centers? It comes over time. They're treating them, they share them. And it's actually, even when you tie in the 340B program, it becomes critical because there's a federal statute that says you can only serve your patients. So you have to have a definition of who belongs to whom, right? So that's something I think is really pretty easy. Now, what's hard is having the centers. So you're talking about the hub and the spoke, but once you have those centers set up, where the patients go, it's going to be their choice. It's going to be patient choice, and they're going to be meeting certain standards because each of those 3 or 4 or 2 centers are going to have standards which CMS and the feds have said, these are now federally funded sickle cell centers. And this is what we expect. If you're going to call yourself a federally funded sickle cell center, this is what you have to have. And that's based on the recommendation of the National Alliance of Sickle Cell Center, you know, whatever. But I'm saying where the patients go, that's easy.
Okay, can we go to the chat? Okay, any other questions from the audience? Any other questions from the audience? All right, well, thank you, everyone. Well, it's recorded. We'll take all your thoughts, and ronald.klein@cms.hhs.gov, easy to find. Thank you very much for your thoughts, and enjoy the day and enjoy the rest of your day.
Thank you.
Thank you.